We are going live. We are going live. Yes, we are live now. So let's wait for 1 or 2 minutes so people can join.
I can't manage those.
So I think I can start now. Hello, everyone. Welcome to Janitri Varta webinar series. This is the very special topic, labor room protocols in modern obstetrics. And I am Arun, founder of Janitri. Janitri is a very dedicated company towards maternal and child healthcare tech-focused product, where we are trying to solve problems through technology in mother and child healthcare. I think I really cannot see the best panel than this for the labor room protocol in modern obstetrics. And we have the experts from across the country in this. So at Janitri, we are actually working on intrapartum monitoring improvement, because every second is a golden second in this phase. Every decision has to be made early, so we can literally save life. More than 99% of these deaths are happening in developing countries, and what we lack of the resources in terms of human, what we lack of in terms of skill or the devices. So through this webinar, we will be taking ahead, what are the different protocols could be there in the modern obstetric, and this is coming based on the expert comment, and across the country we have people. So I would definitely like to welcome each and every one of you for accepting this webinar, and I will definitely want to take these names. So I would like to thank Dr. Leela Vyas, Dr. Sadhna, Dr. Mitra, Dr. Achla, Dr. Manju, Dr. Surekha, Dr. Tamkeen, Dr. Vijayalakshmi, Dr. Sukumar, Dr. Nivedita, and Dr. Rita. Thank you in this specific, very special webinar. I'm sure participants can learn what from your experience, from your learning, and they can literally provide the better protocols, better experience for their patient during the labor ward. So from here onwards, I will be handing over to Dr. Rita, and so Dr. Rita, who is an obstetrician based in Gorakhpur, and I will definitely let me introduce Dr. Rita, and she is also pretty popular in that way, associate professor at BRD Medical College. She also, as a scientific secretary, COJS, she have awarded a gold medal in UP COJ 2007. She have a very great interest into the publication research, and has attended many conferences and seminars. So Dr. Rita, it is over to you.
Yes, thank you. Thank you, Mr. Arun. Good evening to all respected faculty members and participants. I, Dr. Rita Singh, welcome all of you for this wonderful evening of today's academic session. Labor room is a part of our everyday life. And when something becomes so common and usual for all of us, it becomes very important for all of us to take some break and give an insight to our day-to-day practices, because we are not only catering the obstetric population but the future generations. So there is big responsibility on our shoulders. So by improving, updating and innovating our labor rooms by resources, skills and evidence-based practices becomes very important. We have made significant progress in addressing the issue of maternal mortality in last 25 years, but still we have to go, we do a lot, and simultaneous reduction in parental mortality is suboptimal. We have so improving quality of healthcare facility during the time of delivery is one of the most important impactful strategy to reduce maternal and perinatal mortality and morbidity. So I assure all of you that by this webinar, you will get a comprehensive update for practices in our labor room by learned and experienced teachers of the whole country, from our country. So I first welcome our chief guest, Professor Dr. Leela Vyas ma'am. Ma'am, I welcome you. Professor Dr. Leela Vyas ma'am she's former senior professor and unit head IVF consultant of SMS Medical College Jaipur. Presently, she is senior consultant at Cocoon Hospital, Aesthetic and Cosmetic Gynecology at Vyas Clinic, Jaipur. Her contribution as Foxian, she is presently chairperson at ISA Rajasthan 2020. She has been Vice President Foxy 2018, President Narchi Rajasthan 2016-2017, President Jaipur Option Gynae Society 2013 to 2015, Secretary Jaipur Option Gynae Society 2005-2007. Madam, I welcome you for your guidance as a senior teacher and for your kind words. Madam Leela Vyas ma'am.
Good evening, everyone. And at the outset, I convey my sincere thanks to Dr. Sadhna and whole team and Janetri for giving this opportunity. Rita, you are making some high. All my colleagues are here. All are the teachers from the medical college, HODs from the medical college. Yes, we all know this labor room protocols are so important. And before starting, so what is the aim of doing this protocols? Why we are thinking of that protocols? Means our aim to do any protocol is to understand and to demonstrate appropriate knowledge, skills and attitude in relation to the labor room practices. And the ultimate aim is to have a safe delivery. And by following all protocols, we all know that there is increased responsibility of the healthcare providers. Yes, definitely we have to take this onus on our head, all our teachers. It becomes our responsibility to follow these protocols by all our resident doctors, our junior consultant, senior consultant, our paramedical staff and other staff working in this maternity care services, those who are providing. So there should be, we all know that this health in 2018, when I was vice president, our president has given that this, you should have this QED, that is the quality care should be there, ethical practices should be there, and definitely the dignity. Dignity, we always said that dignity should be on both the part. We should be, the doctors should be have their own dignity, and we treat our patient with respectful care and all this. So we all know that the all time the Foxy is working on that. We start from the preconceptional period to their conception, then their antenatal part and the postnatal part, means intranatal part and then postnatal part. Everywhere we need some or how the protocol should be followed. And this dignity, which as a teacher we all know, it becomes in a busy labor room we are entering in there, we always see there one or other some mashes going on. And we start shouting in front of all our patients to our residents. Yes, everyone doing this mistake, but we have to try that. So that's why we always say that dignity of all of us is important as well as the patients. Why we are talking about the protocols? There are 2-3 terminologies. One is the protocol. Other thing we say there is some standards of care are there. And then we say there are guidelines which we have to follow. And we get the policies from the some authorities that this is the policy has been made and now you have to follow. So out of that, so protocol in general language, if we talk about, this is one of the agreement between sometimes if we are working for any official ceremony, and then we say that, and internationally we say that this protocol we have to follow, the international person is coming in like that. So this is one, we can say that this is agreement. Somewhere we can say by dictionary goes, somewhere it's a type of rule which we have to follow this. It describes why we do this, follow these protocols, where to be done, and when and by whom it is to be done. But how to be done is always a question associated with the protocols. That's why you see there are different changes in that. If you are talking about the modern era of this obstetrical practices, I have experience of working in government setup for the last 35 years. And for the last 2 years, I'm working in private setup. And it was my choice that I'll go and see that how in the private setup everyone is doing. So that's why, and by choice, I joined one of the hospital, which is called in our Jaipur setup, which is called as a 5-star, means all affluent classes coming over there. Then I joined one of a medium men running nursing home, and that too is a Manyata certified. So here, the part of that Manyata, as a Foxian, if you say, Dr. Sadhana Gupta is one of the senior most champion in the Manyata, and she has worked a lot, even in the small nursing homes, middle size, and even in the Bombay, we have seen that. Not we are trying also in the Jaipur that these all hospitals, which are the corporate hospitals, there should be the Manyata training should be there. So these protocols, if we set, definitely it becomes our responsibility to follow these protocols, and our all not, I'll say not our subordinate, our colleagues and our team should follow these protocols. And this protocol, the various parts, we start with protocol, how the patient, if patient get admitted, how to do with that, how to receive these patients. Even we start with that antenatal care, in counseling during that. I saw that everyone was worried about the birth companion, how to make this. We have made a protocol that the birth companion should be there. But the question arises, so many limitations are there. The small nursing home has some different, bigger nursing homes have different, and in government setup, there is a different issues are there. But I have seen that in government, it becomes a more easier to call. Initially, we were thinking that it's very difficult to call that, but always that. So we always in Manyata, we have trained our colleagues regarding that acceptance of this birth attendant, that if you are a single man or only a single nurse is there, she will be helpful to you. But before calling that, it becomes our responsibility that they are to be trained or they are to be counseled previously in their antenatal period, whether your mother-in-law, your mother, or your husband who wants to come. And another thing occurs that birth companion, when the husband says, no, I'll come in labor. So if you are coming in labor room or you are coming in the OT, are you able to see that cesarean? You will not get fainted if you see the blood, because it has happened. So we always say, yes, you go and stand by to the anesthetist, to the head and side of your wife. You should stand there. And last time in one workshop, I think Dr. Sadhana was also there, Dr. J.M. Madam. She said that I asked one of husband that if your wife is crying, you should cry. So these are the things which you feel that how the labor is going on. So birth companion, if husband is coming, yes, definitely it's a very good thing in this. Then different parts you all are going to talk. So I just wanted to say that protocol means we have to make ourselves to understand that our aim is to provide a safety during their delivery, means their antenatal, respectful care during antenatal period. They are in safety during their birthing time. And then postnatal, yes, counseling is very important. That is to be done. And then because their life is not finished just to deliver after that, because the postnatal and after that period is very important. So all protocols, because you all experts are going to dealing with this. So what is the reality that in medical college, what happens? There are the different units, and every head of that unit has their own criteria. If you want to set something, as I've explained that, if it is a guideline, because guideline is always evidence-based things. So everyone, so no one say that, yes, this is because sometimes you ask the resident, they are saying, oh, this unit is not preferring these things. But when as a HOD or the other, if responsible academic counselor or of that, then you say that, no, this is the guideline and this you have to follow. The policy, if the government says, like the Laksh is, it was in Rajasthan, it was not initially into the medical college. And I tried to convince all our NHM protocol officers and all that you should bring in that. They brought into the medical colleges, but they are not happy. They say the medical college persons are not ready to listen us. So what happens in the medical college? Because the different persons are there. But it's not the problem only in the medical college. I've seen in the private setup also. What happens? The multiple consultants are coming. Any of the staff, those who are working or the residents are working, you say that you have to follow AMTSL. Madam, how I will do? The another one person is saying, no, give methagen. Someone said, no, give IV oxytocin. So we are not, so in our peer group, we have to set their mindset in a same track. Then only these protocols can be followed. And there is a one in North India, mein hum log bolte hain ki danda hona bahut zaruri hai. So with the danda, everything is ready to accept the things. So that's why these protocols, these are to be fixed. Means we have to say that these are the protocols which will save you. And if you add a one point only, that is the medico-legal thing. In Manyata, it was a very difficult to accept by in periphery area for this max self-regime. They say, ma'am, if any patient have second fit after giving this that. In this, there was a one means town is there, Nagaur district, that is a district city, but so there were 5-6 nursing homes in the same room. I went there to just to assessment for that day. It was a 3 centers. I had to ask them, if every 1, 2, 3, you are all are in the queue. If everyone is giving same thing, if you are setting your protocols by the Manyata, you have been trained like that. So who is going to tell the patient that the patient has expired because of that? If one patient is saved by this Mexel, the message will be propagated by these public only that yes, our patient has been saved. After that, recovering from this condition, if they want to shift these patients to any higher centers, you can allow them. If you want to take, you take them. But if a patient has been given a loading dose of Mexel and then you are taking to any higher center or any medical college, yes, definitely. We all, when we are practicing in the medical college, we always said, what has been given, you show your paper. If they say, we always say a praising word. Yes, tumhare doctor ne bahut acha kaha. They have managed you properly. Then the next question comes, why they have sent us? They have sent because if this can be, have some side effects, they have no monitoring facility. So it becomes a responsibility on both the sides, the receiver and so giver. So of those who are referring patients, those who are sitting in higher centers, it should be in their mind that we never criticize any of the referring doctor, because this gives a positive thinking and positively respect to the referring doctor by those who are coming to a higher center. So these are the so many things. All learned faculties are here and every day they are facing all these things. So now I just stop here because these are the endless things which we are talking about, our life we have put into this. So definitely this protocol and all will work, and we should have a one same mindset and we will succeed in our project. Thank you. Thank you very much. Thank you for giving this opportunity.
Thank you, Dr. Leela. Again, I thank for your acceptance and for your very wisdom, like word which coming out of sheer experience. So you have actually set the stage for all the webinar, what are the issues in between, and from the difference of opinion like AMTSL, because I have worked for 5 or 6 years from AMTSL, and now the situation is much better. So thank you very much. And I also wish to communicate to all faculty that Dr. Leela Vyas has done tremendous work in Rajasthan, where the Manyata was not there. And there has been many issues about the quality in the different small cities and the towns, and Dr. Leela Vyas' tremendous work is highly, highly appreciable. So we really value your words, and thank you once again, and over to Rita for the conduct of the main session.
Thank you, Professor Leela Vyas, ma'am. Now we proceed to our panel, the event of today, that is panel on labor room protocols for the modern obstetrics. For that, our moderators are Dr. Sadhana Gupta ma'am and Dr. Mitra Saxena. So I invite Dr. Sadhana Gupta ma'am. She is Director and Senior Consultant of Gynae Jeevan Jyoti Hospital and Advanced Fertility Center at Gorakhpur. So her achievement as academician and as Foxian is so much inspiring for all of us. As a student, during student life, she received 10 gold medals, and during her professional years as academician and researcher, she received 10 awards for the best research papers oblique publications at various national platforms. She's also contributed a lot for the Foxy. Presently, she is Foxy representative to Suffolk, ICOG Governing Council member, corresponding editor of Journal of Gynae India. She has been Vice President Foxy 2016, Chairperson Foxy Safe Motherhood Committee 2011 to 14. She's also received so many awards for her contribution as an obstetrician, academician, and her contribution for the society. She has authored a book on cesarean delivery and vaginal delivery, which was translated in other languages by JP and McGraw publications. So I welcome Professor Dr. Sadhana Gupta ma'am. And our next moderator is Dr. Mitra Saxena. She is also well-known obstetrician of our country. She is MD, DNB, FICMCH, FICOG, and Diploma Endo from the Kiel, Germany. She is Director, Sri Ashwini Saxena Hospital, Rewari, Chairperson-elect, Practical Obstetric Committee, Foxy 2021 to 2023. Presently, she is North Zone Coordinator, Ethics and Medical Legal Committee, Foxy, North Zone Coordinator for Breast Committee, Foxy. She has been the past president, Rewari Obstetric Gynae Society, and she is project director of Mukti, an initiative.
It's okay, Dr. Rita Singh, please.
Yes, yes, ma'am. Now I hand over to Dr. Sadhana ma'am, Dr. Mitra ma'am.
Let's get on with our panel.
Yeah.
I request, first of all, before I slide share, because the screen will be when Dr. Mitra, you please introduce all the panelists. Please.
A very good evening to all my friends, all the respected, esteemed panelists. And out of the 7, and 5 of them are those I know as excellent teachers, excellent obstetricians, personal friends, and the 2 that I will be knowing today directly is Dr. Sukumar Barik and Dr. Nivedita Datta. And I will just be, I know everybody's CVs are very long and very accomplished achievers we have, but I just want to say a very warm welcome to Dr. Achla Batra, who is the professor. Can I have her CV, please? With all my apologies to my worthy panelists, I will not be reading out everything, but yes, the most important information I will definitely like to give. Professor Achla Batra is a wonderful teacher, and the best thing is that now she is the president of AOGD, and she has achieved, she has headed NARCHI. She is a very prominent figure of Delhi and an excellent person, excellent obstetrician, won many prizes for her society and for herself. And welcome to you, Dr. Achla. Our next panelist is Dr. Manju Puri. Professor Manju Puri, well, I know her for over 43 years. We've been class fellows, and I'm so happy to welcome you, Dr. Manju. She is the professor and HOD of Lady Hardinge Medical College. And as we all know, that she's an excellent teacher, excellent obstetrician. Wonderful to have people who walk the talk. Dr. Achla, Dr. Manju, And she, in keeping with her wonderful personality, she has won many awards and authored so many books and so many papers. And she's a, I mean, I'm not going to read. Please, everybody, we love you, Dr. Manju. Next, I have a very charming lady, Dr. Professor Sureka Taide. Her CV is also extremely long. I will just say she is the beauty and the brains together. Not to say that Dr. Manju and Dr. Achla are not good looking. All of them are wonderful, beautiful. And Dr. Sureka, as I have made a very good friend of yours in my journey in Foxy, she is so knowledgeable and so beautiful. And she has many accomplishments to her credit. Dr. Tamkin Khan, I had the honor to listen to Professor Tamkin Khan, who is from JNMC AMU Aligarh, a wonderful teacher, very beautiful, all the academic accolades, and very warm welcome to you, Dr. Tamkin. If you give a topic to Dr. Tamkin, I mean, in keeping with the rest, the other three, she's the next person. She will just cover it comprehensively. Very warm welcome to you, Dr. Tamkin.
Thank you.
And then, my dear respected Dr. Vijay Lakshmi Shashadri, Madam is a senior consultant at Sundaram Medical Foundation, Chennai. I don't know whether she knows it or not, but I have been a very regular visitor of Chennai to Progress. That's how I know Sundaram Medical Foundation. I'm sure Dr. Shashadri is going to give us lots of good inputs from the private sector and being in academics as well. She's the past vice president, she's the vice president of I'm trying to shout, but why?
Now it's okay. Now
Okay. And a very warm welcome to you, Dr. Vijay. And like all the predecessors, she is extremely accomplished and a very good organizer as well. Our next panelist is Professor and Head of the Department, Dr. Sukumar Barik. Very warm welcome to you, sir. I'm sure you are going to give a lot of inputs from your experience. And truly, Dr. Sadhna has made sure that we have representation from all the four corners of India, the North, the West, the South, and the East. Sir is the East Zone chairperson of ISOPAV and published many articles in national and international journals, delivered several orations and many guest lectures, and received many national awards. We will all be looking forward to your wonderful inputs. And Dr. Nivedita Datta, very warm welcome to you. You look to be the youngest out of the panelists, but I'm sure that you will be full of lots of knowledge and enthusiasm. Dr. Nivedita, as I read from her CV, she's a DGO DNB and consultant of OB-GYN in Bokaro, ex-president of Bokaro OB-GYN Society. And she has organized many conferences, presented papers at local and national level, published papers. So what I can see is that all of us are dedicated people in obstetrics. And today I do hope that with all of you, we are going to actually learn ourselves as well. So over to you, Dr. Sadhana.
yes, I'm sharing my slide share, and there is a lot of discussion. Few points we have like emphasized, and which needs a little elaboration, and few points which need a real clear message from all the panelists. So I welcome on the myself and Dr. Mitra, all the esteemed panelists, wonderful panelists, and bring greeting from Foxy and Cephog. With welcome all. And actually, it is the protocols and it is the modern times. So many times when we do the things, and there is a lot of things because time is running so fast and changing so fast that we are not able to set our place in how to behave as a doctor and how to follow with the constant ongoing research as well as pressure from all sort of media, from electronic to print to social medias. Every time we are in the limelight, what went wrong, what should be done and what should not have been done. So we have to make ourselves grounded. Always we have all these educational things because we want to look back, we want to sit and think we want to frame good future, and with the all time when the human birth is always there. So what is the thing? First of all, Dr. Leela has said it is quality, ethics, and dignity. And before that, our thought process is that we are giving care that is of utmost importance for the 25 million births happening in India. Now there is a suddenly a noise that there should be humanization of childbirth, but we know at the same time that the human birth, particularly human species, is the most difficult journey of human life for fetus in terrain and suffering, and it is a very difficult part of the for the mother as well, especially in low middle income countries when the people are not accessible to what is said a very high quality of air. So we are like we are imbalancing it. It is a physiological thing or the potentially pathological thing. So with all the panelists, this is the set the stage that for acquiring knowledge we have to study, but for achieving wisdom we have to observe our time, our people, our technology, our partners. So women have been always delivering in all species, but the labor management in human birth has changed drastically in civilization and technology. So we are coming to the point, it is 25 million births, and what should be done which is safe, which is effective, and what should we should leave behind which is not safe, which is not effective. That is the issue of today. And first of all, protocols, like Dr. Leela says, that it is difficult to define. My first question is to Dr. Achla Batra and Dr. Sureka, who is heading the institution in different settings and in a different state. What is the protocol? How you perceive that there should be protocols for the labor management, which is that much part of our OB-GYN, basic OB-GYN practice, and if we follow it, does it have the efficacy and efficiency in obstetrical care? Does it really improve, or it doesn't matter? So Dr. Achla Batra and Dr. Sureka.
Uh, Good evening, and thank you for making me part of this wonderful webinar. Labor and delivery has very profound effect on the woman's physical as well as psychological health. And during labor and after labor, there is maximum mortality and morbidity. In my own institution, Safdar Hospital, 70% of the maternal mortality is in the intrapartum or postpartum period. And with the, we had the Millennium Development Goals and we had the Sustainable Development Goals, which said there should be facility-based deliveries. And the deliveries in facilities have increased. This has probably led to overloading and slight decrease in the, quality. So we need to have protocols because protocols provide us with uniformity of care. Protocols provide with the opportunity to train, uniformly everybody. They provide us that we can monitor what we are doing. And they can also help us to observe and have auditing and accountability, what we are doing. Besides that, if there are protocols, it's very easy. If you're following the protocols, anybody, even the junior-most person, can at least do the first few things which are required. And if we follow protocols, then we can ask the policymakers that we require this. This is the infrastructure we want. This is the supplies we want. And so if we have protocols, a lot can be done. And with the changing times, new things are coming. So our protocols are also changing. And protocols will also help us. The most important thing which is emerging nowadays, the respectful maternity care. So if we have protocols for everything, we can also provide a human and respectful maternity care to the mother. So I think protocols are very important.
Thank you, Dr. Achla, because we have to need some recommendations, some evidence-based medicine, and a clear roadmap for right from the head of the unit to the last person, that is the junior nurse or even our fourth class staff. Dr. Sureka is heading institution with the name of Gandhi and Vardha. So we have a special respect for that. And Dr. Sureka, what's your experience that how you in your headship, how you like to define protocol and how you perceive the efficacy of having few protocols in labor management.
Thank you very much, Dr. Sadhna. And yes, I agree about having standardized care. Now, when we say standardized care and when we say standard, we are talking about quality of care and we are talking about patient satisfaction. The birthing experience has to be such that what we call as the client satisfaction comes to be at the topmost. Now, being from a rural area, I understand, and we all understand that different intersectorial differences are there in throughout the country. When we look at throughout the country, there are intersectorial differences in what kind of care a lady receives. If she belongs to a higher strata, then the standard of care is different because she goes to a better hospital with a better infrastructure. And when she's a rural woman who doesn't have any saying in her own care, then maybe the standard of care becomes different. That's why in my setup, which is a rural setup, and you said Gandhi's name is there. Now, in that setup, we have to assure with the help of these protocol, which define certain guidelines given on a global level with the help of evidence. So evidence is there to support certain interventions which may be needed and give us a best outcome, and certain interventions which are not needed at all and we have been practicing for so many years. So now we have to unlearn all that and relearn new things so that we give best of care to our women. So that is what we have been doing with the help of Government of India, which has given the first mother and child health wing to MGIMS Sevagram. With that, I was there in Sevagram for 20 years, and that was the first unit which has used these guidelines, and we could in a rural setup also we could follow all the guidelines given as per Lakshya guidelines of Government of India. All the guidelines could be followed in a rural setup also. So that is what we want to say. And of course, as we follow the guidelines, both maternal as well as the fetal outcomes become much better, and you will find not only the outcome becomes better, but certain interventions like cesarean sections, like episiotomies, so all these interventions which are unnecessary will definitely come down, and you're going to definitely have a harmonized care between all units. All your consultants and residents are in the same platform. You don't have to fight amongst yourself because those are the protocols, those are the guidelines, and they are evidence based, and you need to follow them.
Thank you, Dr. Surekha. So for all the participants who are there, first thing that we have to have the labor room good protocols. And secondly, Dr. Surekha has pointed out very importantly that it is not restricted to certain class or certain residency. We owe this minimum quality universal obstetrical care to all our women and the children. So clinical standard is a quality statement that describes the care patient should be offered by health professional and health services for a specific clinical condition in line with current best evidence. And we have to be clear what to be done, when to be done, and how to do it done. So coming to admission, Mitra, you want to add something?
I was just thinking to present this question in a different way, because to the audience, I represent an ordinary obstetrician who is in a standalone practice, and we have.
I think we can put this question to Dr. Vijaya and Dr. Nivedita.
Yeah, exactly. So yes. This next question of mine is being addressed to Dr. Manjupuri and Dr. Vijaya. Please change the slide, Dr. Sadhna. So we have booked patients and then we have unbooked patients. We would like to be discussing now this, that in a government setup or in a private setup, if you get a primary gravida, you have two options. One is a well worked up patient who comes in labor at 40 weeks at 2 a.m. with all her record, and another similar patient but no record. So from your point of view, the message, Dr. Manju, you would like to give, and Dr. Vijaya, in your setups, that how would you manage this patient at the time of admission? What is the importance to the record? How it is going to help us in formulating what will be the, right now she's in early labor, but please take the question. I hope you do understand that the connotations are so important. One a patient with record, one a patient without any record, similar findings. And let's take it that she's only 2 to 3 cm right now. Dr. Manju Puri, please take the case.
Yeah, thank you for the question, Mitra. So basically, when we talk about a government hospital, so you could have both kind of scenarios. A patient might come with the records when she's a booked patient, or she might just walk in when she is absolutely an unbooked patient. So whatever the case may be, so the first and foremost is that, when she reaches the emergency room or the casualty, I think the thing should start that the patient should be greeted by she should feel that she's welcome there, and she should be attended as early as possible. And if in case it is a heavy load facility like we have, there is an absolute need for triaging. So, because a lot of patients come, some of them may be very sick, some of them may be referred. So our CMO should know, there should be a triage mechanism in place. So basically, we are in the process of developing it. We have almost done our protocols, and we should be doing it very fast now, because right now we did not have. So we've decided that the patient should be labeled as red, yellow, or green. So red would mean that anyone who really needs immediate attention. So, then the CMO takes over it. And the triaging can be done by the nurse or the intern when we talk about a hospital, or maybe the junior resident. And then they should be able to look after the patients according to the priority. So that is one part. Second is, when a patient like this comes, you have to review whatever is the history. So that would mean that you have to assess the patient. So assessment, triaging, and then the management. So this is how it should be. So I think when we talk about the admission, most important is that the patient should, most of problems arises when you are not prompt in kind of attending to the patient. So who needs attention when is the main, focus point on which all the problems arise, all the fights, all the, violence, all that starts, at the entry point only. So for me, I think that is
very, very right. That triaging, let us not leave any patient unattended, is the message you want to give. Also, Dr. Manju, if an unbooked patient comes and she's in labor, she needs, would you be advising that all her investigations should be run in an emergency so that her risk stratification is done? What would be your message to the audience?
No, I think whenever this kind of a patient comes, and in case the investigations are not done based on your clinical assessment, you can either take her directly to the labor room, because she's going to be admitted. She's got bleeding and she's got pain. She's 40 weaker. So yes, she definitely qualifies for admission. There is no doubt about it. So this would be definitely taken in case the investigations are not done, then they are done on the emergency basis once she's received in the labor room. So we are not going to ask her to wait there. She does not need any stabilization. This patient needs the admission straight away. So I think that is what needs to be done. So without the patient should.
Thank you. Dr. Vijaya, will you please tell us about your
hospital
facility? Yes, first please describe your facility, and then what are your protocols?
Yeah. In our facility, actually, we have most of them are booked cases. Now, unbooked cases don't come generally, because ours is a corporate private hospital. Now, but even if emergencies come well in labor and unbooked, obviously we are not going to push her out, and we are going to take care. Now, the booked cases, just like the case you have said, 40 weaker and in labor with a little bleeding PV, whether it is show or whatever, we have one area just by the side of the labor room. So they are all directed straight away there the moment they enter the hospital. So they are already aware, because during antenatal checkups, they know that this is a particular place they have to go. But that apart also, they land up there. And then in the room which is close by, that is the main triage area, where there is always one doctor who is because we have DNB PGs, so they always help us. But so there is one this PG who will receive this patient who is already a post DGO patient doctor. So anyway, she will receive the patient, and also one nurse is always there. So these people triage, look at the need for her to come over and why has she reported and what has been done and whatever. So if it is a real urgent case, straight away she is wheeled into the labor room. Otherwise, here they have a facility for CTG and fetal heart. The initial assessment is done, vitals and everything, and then is directed into the labor room. We always have one consultant on duty in the labor room. So the initial triaging and assessment and documentation writing and everything is done by the postgraduate who is on duty, or sometimes even the registrars and senior registrars are on duty. Otherwise, any sudden emergency or severity, the consultant straight away takes care. But of course, these are all booked cases, so they are booked under particular consultants. So if there is a little bit of time, then the consultant can always come in and assist. But if not, then even the consultant who is posted there will take care till this consultant reaches. So no patient is neglected, or there is not much lag between the patient's arrival in the hospital and then taken care. But most of the nursing staff, all the registrars, PGs, they are all following a particular protocol. We have protocols in place because different consultants, different this, so we cannot really confuse these juniors. So we have protocols and they usually follow. But at the same time, there are small areas where you need to deviate from the protocols at times. But that apart, see, for example, ectopic means they would come straight away to the emergency room because they have gone in for a bleeding and all, which is again in a next floor. But then from there, they are straight away directed to the labor room as well. So this is how, and we do admit all the cases who have problems of this. But in the triage area, if we find, because you had asked about the admission, if this is not the case of a 40-weeker and still she has time, we do not admit very early in labor. We tell them, okay, if you're okay and uncomplicated, you can go home and come back. That allowance is also done. Of course, talking.
So actually, that is the important take-home point is this, that no laboring patient should be left unattended. See, all of you all have got big facilities, you've got a big team, but for the people like me who are single-handed, the clear take-home message is, if you have the record, fine. Otherwise, immediately look at the hemoglobin or whatever and examine, and then follow your admission protocols if and when needed. Dr. Swadna, over to you, ma'am.
So thank you.
Can I make just a small point, Dr. Sadhna?
Yes, sure.
What I keep telling my residents is, and time and again I tell them, because we have n number of residents coming in and out. So I tell any patient who walks in the middle of the night is not a patient who should be sent home.
Yes,
that.
She has come. She needs attention. That is
and she needs to be looked after. Don't send her home back. No one would walk in the middle of the night in case they do not,
unless required.
Problem, which is really disturbing.
And from a private practitioner's point of view, Dr. Manju, for all the private practitioners, if any patient comes with pain abdomen anytime, please go down and see yourself. That could be
Mitra, that is the very, very important message, Mitra, because that is the problem, that the patient comes in night and when the consultant comes in the morning and they say it was hypertension or low-lying placenta, and then all discussion and the conflict starts. So this is very important. Or train your nurses and resident how to read ultrasound, how
examination by yourself. Examination,
if possible. So thank you very much. And now we are coming to the second thing. First is triage. I think we should have the triage. Patient should be attended, and all the risk factors should be screened at the time of admission. This is the one message from all our panelists. So now this patient has normal record, antenatal, HB12, everything is normal. She is 40-week pregnancy, gestational age, no IUGR or large for day, Dopton, fetal heart rate 140 per minute, 3 centimeter dilated, 30% effaced, and she is having contraction mild. So now with this all good technology which is supporting our maternal labor monitoring. There are few questions that when we do this thing admission protocol, do you advise admission CTG at the time of CTG? And when we find that this patient is in labor, what's your takeaway? How you instruct that she should take food or she should be hungry, she should walk or she should lie down, and he should have the IV line or not? So the first question, which is actually a good issue in the medical circle all over the world in the obstetrical care, that admission fetal CTG. So what's your take away to, I think, Dr. Nivedita, Dr. Tamkeen, and I'm not here.
Dr. Sukumar.
Dr. Sukumar, because something is coming before. So Dr. Sukumar, we will start from Dr. Sukumar. He has done a very good webinar on CTG. Admission CTG, what's your takeaway? It is necessary or it is not that so? And then we will go to Dr. Tamkeen and Dr. Nivedita. Dr. Sukumar, please.
Thank you very much. I think there are, if you follow any guideline, then admission CTG for low risk pregnancy is not a advisable thing. That's if you follow the Royal College guideline or even WHO guideline, does not recommend routine labor admission CTG for low risk patient. It is yes for the high risk group, but not for the low risk group. But that's the guideline. But that can be followed particularly in the high output group. But majority of the private sector, where the output is little low, I think majority of the people will advise admission CTG for about 20 to 30 minutes. And if it is normal, that should be all right. Means a strip of 20 to 30 minutes, if the baseline is fine, the baseline variability is fine, there is acceleration and there is no deceleration, we are very happy to say that this is normal. The guideline which is suggested for low risk patient is not conclusive, particularly in the developing country setting, because there are people who has never been seen before. In those cases, you don't know whether she is high risk or low risk or something like that. So what I will suggest as a protocol, if the logistics permit, then a short strip of liver admission CTG is advisable to all, irrespective of low risk or high risk. But the logistics doesn't permit, means if the throughput is so high that you cannot do, then probably the low risk will be excluded and only the high risk will go for that. That's the take-home should be.
Thank you very much. Yes, continue, please.
So, because labor admission CTG interpretation in our country is very, very different. So far, the records and the publications mostly done in West, but there are 2 or 3 publications which is done in our country is in favor of doing labor admission CTG even in low risk patients.
Thank you very much, Dr. Sukumar. We really wish to listen you. And before going to Dr. Tamkeen, who is in institution, I will like to have opinion of Dr. What we say, the underprivileged situation that is Bokaro. So what's your Nivedita? You are doing admission CTG for all your cases or only in high risk case, or you have to check the patient particularly that do CTG or don't do CTG? What you are doing, Nivedita?
Actually, since you've already mentioned, I'm working in a resource constrained setting. So I do not do admission CTG routinely for all my patients. For low risk patients, I do not do admission CTG. But I would like to point out that my nurses are instructed that they have to do a fetal heart rate monitoring at least for 2 minutes for every woman in labor at admission, and she has to note the decelerations which are occurring. So my nurses pick it up very well, and they let me know ki nahi ma'am, with the contractions her heart rate is going down and it is staying down or it is coming back. They give me that information, and that is how I follow it up. The second point is that whether I see all patients who come in labor, it is really not possible for me, because with a hectic OPD and then seeing all your antenatal, all your intranatal patients at every visit, then I would be like working 36 hours a day.
Thank you, Nivedita, for bringing up this point, because we also say that it is not possible for obstetrician with all the things. So thank you for being coming up. And my point is that have you ever regretted that we missed the fetal distress or some high risk IUGR or the flat tracing, and we get in sudden asphyxia or something? Have you any time experience?
No,
What
I
Dr.
have
Sukumar
I have not done it. I think the problems is I've not really missed it out. I mean, I don't know. I've not such complications
Okay.
haven't occurred. Touch wood,
So,
they haven't really occurred. I keep my fingers crossed.
So, Dr. Tamkin, we will have your takeaway that what you do in your institution, and if you are doing a private setup also, what's your recommendation for admission CTG?
We are not doing it. No admission CTG for us at
Okay.
our institution, in spite of having 5 or 6 CTG machines all the time in working order, because the evidence is against the use of CTG for all patients. Why? Because there's a very high false positive rate. It increases the incidence of operative delivery, cesarean sections. At the same time, you have to, if it is not reassuring, you have to repeat it again. It's a very high output setting, and we don't want to waste time. And because evidence is that intermittent auscultation with a stethoscope is equally good, so there's no need of doing a CTG. And the cost of the paper is also a lot. We need to have, it's a recurring, expenditure. So that is why we are not using it. And because the evidence says so, only the most important thing is when you are not doing it, you need to do a the mother. So whether the baby is IUGR, whether there is oligohydramnios, whether she's a case of previous cesarean, or most important, whenever you think in terms of augmented or induced labor, they are all very high risk for fetal distress. And again, you have to have a very high index of suspicion to rule out IUGR when the patient is coming to you as an emergency case and you don't have an ultrasound at that time with her. So thorough workup and no admission CTG. For low risk, for high risk, yes, we do it. In fact, the recommendation is that if the patient is coming to you with labor pains and she's going back because she did not go into active labor, it was a false alarm for us. So before you discharge the patient, do a CTG half an hour before she leaves. More of a for safety for litigation, that's all. So if it's a low resource setting, all the more reason. High output, low resource setting, all the more reason not to have a protocol admission CTG in place, because it's going to definitely going to increase your workload.
I will like to add, not as a moderator, but as a panelist also in this panel, because 1 second only. I go with Dr. Sukumar because he said very pointedly as per the logistics, which are very, very important thing. When you are single-handed, admission CTG, even in a low-risk patient, actually, if it is reassuring, over a period of time, your own staff gets so well trained that they take out the admission CTG for just 10 or 15 or 20 minutes, and they are able to also do the risk stratification. So in my own setup, I find, yes, the guidelines say that low risk don't, but practically every patient in labor, if you can afford to do it without increasing the cost in the patient side, it is extremely helpful, because any low risk patient can become a high risk intrapartum. So it is extremely important to know at the outset what was the reserve of the baby, and reading more and more about CTG and how the pathophysiology changes It's extremely informative and very little of error. Input from other panelists, please.
Thank you, Mitra. I think admission CTG, I also do my admission CTG in all patients. Like, because
Can I just answer this?
Yes. So
can I just add something to this argument?
Yes.
It has to be half hourly monitoring, which is going to prevent, your patient escalating from low risk to high risk. You cannot predict.
Yes.
It is something evolving, something dynamic.
Totally agree.
So again,
I totally agree with Dr. Kamkar.
Absolutely.
So we are having a good fight, and I think with that moderator take the lead. So this is what Dr. Tamkin said. The evidence says that yes, it results in a little more intervention, but people are doing it admission CTG because, like in the 2 months ago, when we have CTG, like if you have a flat tracing, you cannot detect it from the doctor. And these patients come suddenly with the thick picori. So we don't know that what is the size. So if you are doing admission CTG and you are comfortable with your practice, then continue to doing it. If you are something very heavy load, like Dr. Tamkin say, paper cost and everything, you should be very, very through for your record and picking up the low and high risk cases. So that is the thing, and interpretation is also very, very important. It is ye move nahi kar raha hai. Hello. So from admission CTG, I think yes. So this is the slide which shows that the admission assessment. So there is a long list of maternal, fetal, and intrapartum risk factor, and many group of patients, 60, 70, like previous section, a very large section, preeclampsia, postpartum, PPRM, induced diabetes, antepartum hemorrhage, fetal problem, and there are a long list and many large section of group patients come into this category. So if you are doing admission CTG, it's fine. Otherwise, you should be very, very thorough. So it is from this thing, from intrapartum fetal monitoring in your institution. Again, I think we have covered a little bit that what is intermittent auscultation, how it is role, but we want to have the thing that how our panelists are comfortable with intermittent auscultation with stethoscope or with the Doptone. And can you have the combination of sometimes CTG after 2 or 3 or 4 hours, and otherwise it is a Doptone assessment. So what's your takeaway to the audience about intermittent auscultation?
This.
Yes, you can take it, I think.
Okay. So I will now request Dr. Achala Batra and then Dr. Tamkin to throw light upon this, that if you're not doing admission CTG and you're monitoring by intermittent auscultation, what would be the instruction to your juniors, to the nursing staff and the residents?
So when we are following with the intermittent auscultation, we always tell them that they have to auscultate during a contraction and also after a contraction. Just doing it anytime is not enough. And because if there is some deceleration after a contraction, they would miss it if they don't do it. Plus, every time, after some time, they also have to see the maternal pulse. Sometimes, the maternal pulse is mistaken as fetal heart rate. So that is very important, that during contraction and after contraction, both they have to monitor, and at least for 1 minute. Without that, the intermittent auscultation is not enough.
Dr. Tamkin, please, can you add?
It has to be every 30 minutes during the active phase of labor, and the second stage, it has to be every 5 minutes for low risk. And for high risk, it has to be either CTG, or if you're doing it intermittent, it has to be 15 minutes and continuous with the stethoscope during the second stage. And like Dr. Achla already said, it has to be before, during, and after a contraction. And of course, you have to keep the maternal pulse in mind as well.
A point of this thing, will anybody have any suggestions regarding assessing the beat to beat variability by intermittent auscultation? I think Dr. Manju will be able to tell that one.
Yeah, basically, I would not trust a beat to beat variability on auscultation, but I would not ask my residents to, or anyone to, press on the uterus at the time of contraction. The patient is already having a lot of pain. So doing it post contraction would be good enough for me. because the patient would feel uncomfortable, and there she's struggling with the pain, and there you're with your stethoscope trying to press upon it. So that is one thing. And I also want to make a point on the admission CTG. There was a lot of controversy over it. Look, when we are talking about quality care, we are talking about evidence-based care. So we can justify anything and everything, whatever way it is. But if we really go by evidence-based, then I don't think so any kind of unnecessary interventions should be done. It's not going to give you any information. It is the continuum of care. If no one is monitoring the patient, every half yearly, then there is no advantage of doing that admission CTG. Until unless it is a low risk, absolutely no need. High risk, of course, yes. I'm pretty sure about it.
Dr. Manju, when we were reading Benson, if you remember, Integrated Book of Obstetrics, this was a clinical way to detect B2B variability. They would say that count the heart rate for 2 minutes and every 5 seconds see how many beats are coming. So that actually every 5 seconds you will realize that the number coming is different. So that is a rough way to know the beat to beat variability.
Yeah, that's fine. Yes, you can
Can I
make
add
out.
one thing here?
Yes,
Yeah.
please do add.
Can I add something here?
Please,
I
surely.
agree with most of the panelists that that admission CTG is not needed in low risk patients, and of course for the high risk, different guidelines are there, and that should be followed. Now, regarding intermittent auscultation, apart from the stethoscope, if you use the Doptone, there are many advantages to the Doptone. I can say that. Because Doptone, sometimes the your resident is not able to hear properly, and then they will say, okay, this is the heartbeat. If you have a Doptone, you're not only able to hear it, there is a record on the screen, and also it is reassuring to the patient and also to the birth attendant. So I think there is a great advantage of doing the intermittent auscultation with the Doptone. So for me, I think it's a very simple device. Its cost is quite low, and it can be carried also. And especially if there is a fetal distress condition in which is a severe bradycardia and you're taking the patient to the operation theater, if you carry the Doptone along with you, and then you are reassured, yes, the fetal heart is present, and then you can go and do your cesarean section. So I think it is very handy to have a Doptone in the labor rooms, and that is very much advisable. Even for nursing personnel, when you are talking of task shifting to a midwifery care, I think that using a Doptone would be much better than using a stethoscope.
Yeah.
Dr. Mitra?
Yes.
No, in our
I too
setting,
agree
of
on
course, we do routine admission CTGs, and because it also gives like just a short segment, maybe 15 to 20 minutes, but at least to know about, and we are all tuned, including the nurses, how to at least pick up if there are major issues. Otherwise, we don't interpret or interfere unnecessarily. Our cesarean section rate is quite modest, and it's not just because we see a little bit of beat to beat variability difference or just a lack of acceleration and you take up. No, we give enough time, ask her to again. Sometimes they come without eating anything, so sometimes that also helps. They have some rounds of some food or something, get back and then do. But we are doing admission CTGs, although as everybody said, routinely is not required, but we are always worried. We don't know whether we will miss out something because some cases have happened. Of course, looking at the fetal heart first is important because you have to prove that when the baby came, when the patient came, the fetal heart was good or not good. Sometimes you bit of short segment of CTG because everybody is tuned to that, and we have also an evidence. And of course, Doptone is the one. We do not rely on the stethoscope unless it is really required, because I think as the previous panelist also said, it is very important to assure the person who is accompanying the patient as well. Thank you.
So actually, the take-home message is that what we know by guidelines, that the low risk basically doesn't need admission test, but in your own practice, obviously, if you can afford it, that is the one thing, logistics, without it being a burden on the patient. Let us be ethical also, and to have a good medico-legal safety thing also. And if any other panelists would like to give their inputs regarding CTG and also in low risk, I would add another question, Dr. Sadhna, with your permission, that yes, doesn't need, but would you do, for example, if a patient ruptures the membranes, would you like to do a CTG? If intermittent auscultation, there is a deceleration, would you go in for a CTG at that time so that you have a better idea?
Definitely.
Definitely.
Dr. Achla, please take that one.
Yeah, if there is rupture of membranes, it is, if you've done even auscultation after that and everything is fine, so and the head is not free floating, head is well into the pelvis, I don't see any reason to do a CTG just because she's ruptured the membrane.
No, I said if after rupture of membrane and your nurse has picked up that there is some bradycardia, then would you advise?
Yes, definitely. Whenever we have any high risk factor, we have to do a CTG to see if something is happening.
I would rather do a PV
showing.
examination in this patient. Mitra. Rather than CTG, I would do a PV examination in this patient.
And you down the PV is fine, but the bradycardia was there.
So then, of course, yes. But a PV would be
yes. Dr. Absolutely right. We've had, cord prolapse.
Cord prolapse.
So Dr. Sukumar wants to add something. So please unmute yourself.
Royal College or NICE guideline clearly says that if your low risk pregnancy or in labor, there are certain conditions where you transfer this one, means not having any CTG to have CTG. The patient falls into that category where she had a rupture of membrane and then had a bradycardia. There are many other conditions like that, meconium stent, like augmented labor, sudden bleeding during pregnancy, the temperature, maternal tachycardia. There are a list of when you convert this one to continuous CTG. It is a list of these things is there in a guideline of the NICE guideline, what you are already focusing on. So it is very clear. You are absolutely right. We have to do that thing.
With all the discussion, I really want to emphasize one thing. That what Dr. Sukumar is saying, all the RCOG guidelines and everything, in our all type of setup, we have to be very careful that CTG is not the substitute of personal care and personal evaluation. Like Abhi, like panelist says that yes, we will first do the PV examination. There is sudden cord prolapse or something wrong is happening. So it is not a substitute for the personal care, and the CTG helps us in picking up at the right time, so that there is no untoward hypoxia or acidosis. And as we say, the individualization is the key, and a little bit over towards CTG is not is not going to harm anything. So one thing, it is a question from Mitra, but like the discussion is there. What we say that some panelists say that my nurses are very good in interpreting CTG, but unfortunately, all over the world, we really read all CTG in a different aspect. For some it is normal, and for some time it is very bad. So as a senior consultant, how you minimize errors, like how you train your staff that this is resident, they are rushing to cesarean section, but you say that don't do cesarean section, first you do this and this. So again, any panelist can take it. If Dr. Tamkeen has not added to it, and she is also very good in CTG, at how you minimize these errors, so that there are more intervention. Yes.
Okay. So first of all, talking in general, what are the recommendations? The intrapartum reading interpretation of the CTG is something different than the antenatal CTG. The first is that the baby may have 3 cycles: active sleep cycle, deep sleep cycle, and active wakefulness. So there may be problem in interpretation. Active wakefulness is when there are too many accelerations, the baby is moving too much, you don't know what is the baseline. Sometimes the acceleration will appear like the baseline, and the baseline will appear like a deceleration. So that is active wakefulness. Then there is deep sleep. And again, there will be misinterpretation because the variability will be decreased. This will last for around 40, 50 minutes. You need to repeat the CTG for that. And there'll be no acceleration. So you might think that the baby is not okay. And the other is the sleep, the active sleep, where it is just like antenatal. There'll be accelerations, there'll be normal variability. So these three things we need to remember. Then again, whenever we are trying to interpret, it has to be not the interpretation of the CTG, but the patient in toto, the clinical findings, and you need to work up the baby and the mother. Again, I want to repeat whatever Dr. Sarkar just added. Then another thing is that there should be proper training of the residents in reading to minimize errors. They should know the basic pathophysiology of the abnormalities that occur. And then the consultant should always be there, the helicopter view that is known as. That is a recommendation by RCOG that the senior consultant should always keep an eye over what is happening in the labor room. And then there is a buddy system and fresh ears and fresh eyes system. So the buddy system, what is that? We are doing all the time, working as a team, not just one consultant interpreting, but we are asking somebody else's. And if you see a very interesting finding in the RCOG CTG, they have two eyes there. So that is, if you have, whether you have recorded the interpretation by another consultant or not. So if you have done that, then you tick that for the record. So that is buddy system. And that is also the fresh eyes, because that person is seeing everything with a fresh view. Apart from that, take into account that the circadian rhythm of the residents between 2 a.m. and 6 a.m., that they have the lowest, cognitive, they have cognitive impairment, and they have the tiredness, they're angry. So all that you have to keep in mind. Now coming to what we do, what we are doing, we have a WhatsApp group 24/7. Each and every patient taken up for cesarean section, they put in a short summary of the history, they put in the CTG, the before resuscitation and the after it was done, and then only they take up for the cesarean section. So that is what we added in our system.
So thank you. Actually, WhatsApp is not worsening our, it is a good strain for our eyes, but actually it is helping in labor management also.
Definitely.
Because any nurse can put the WhatsApp and we can see, yes, it's okay, let it happen. So thank you very much, Dr. Tamkin. That was really great idea. And a few clinical message when you see a little bradycardia or variable deceleration and patient is on induction or something, what's your takeaway to the audience that when there is a initial something, what we say borderline CTG, what should be the protocol for immediate resuscitation of the fetus or immediate action? What should we do before taking immediately like knee-jerk reaction for cesarean or terminating the delivery? So,
Dr. Sukumar,
yes,
sir, please add.
What a day, started at 11 o'clock with CTG and now still at 6:15 with CTG. And I'm very glad to say that today is our 45th CTG training workshop conducted by two of us throughout the country, and today was in our state. And at 60:15 also, I have to say the same thing, that the best possible criteria at this moment is to take the FIGO 2015 criteria, and all labor ward should have a photocopy or laminated copy of that one, which shows it can be classified into three clear groups. One, it is normal. Two, it is suspicious. And three, it is pathological. That's it. All of us should say the same thing. Not the reactive, not abnormal. Normal, suspicious, and pathological. And yes, fantastic. It is already there on the screen. And if you look at that one, they have added that interpretation of the CTG is important, but most important thing is to act depending on the clinical scenario. The CTG is a piece of paper, as Professor Tamkin has already mentioned. That is a very, very important thing, that CTG is an investigation. Don't just rely on CTG. It is the clinical background and CTG and clinical examination, interpretation of that CTG, and acting on that. That means if you have got time, then you go for the intrauterine resuscitation bundle. That means if there is a tachysystole, there is more contraction going on because of oxytocin, stop oxytocin, left lateral position, IV fluid, oxygen, and give procolytics. By the time you are taking this thing and then take action, do a examination, whether it is imminent for vaginal delivery or she still needs a section. By the time she's been transferred, that thing can be continued. So this is a very clear-cut thing is already there in the interpartum care of the uncomplicated pregnancy in the NICE guidelines. And I'm very glad at the end of the day also, I'm talking the same thing what I've started saying in the morning. So thank you very much. And I'm very glad to see the same slides here also.
Dr. Sukumar, may I add something that actually, if we understand the very basics of CTG, it is extremely important to understand how the fetus responds to a stress. So how the heart rate behaves under the stress is the whole thing, whether it is bradycardia because of vagal inhibition or when the stage of tachycardia comes, we have to know the ominous signs. And that is, if we understand the fetal physiology very well, the interpretation of CTG becomes extremely simplified. So after deceleration, if there is a rise in fetal heart, it means that the catecholamines from the adrenal cortex of the fetus are being released, which means the baby is already in danger. So it is extremely mathematical and very helpful. In fact, of course, we have to develop guidelines for intrapartum CTG, but a lot of work is being done. And if we understand interpretation, then it can be really put to good use. Dr. Manju, would you like to add something?
And the second stage, Mitra, add to your, continue the second stage, because second stage is the peak of everything. And when there is a head compression and when there is a vagal stimulation, and suddenly there is a lot of hodgepodge, and second stage cesarean and assisted delivery, both are a little bit complicated things. So second stage issue is also there, and hopefully we will cover up in the next session. Dr. Manju Puri, your last comment before we switch from the fetus to mother.
Do not treat CTG, please treat the patient.
Yes.
Very good, very good answer.
Dr. Sadhana, one very important point I want to add is that we all assume that oxygen is going to help. Oxygen will only help when the mother is hypoxic. If the mother has asthma, heart disease or something, otherwise if we are trying to resuscitate the baby with more oxygen, it may lead to release of free radicals. So the standard protocol that we were following as residents, change the position, give her oxygen, give her fluids. Fluids will only help if there is dehydration, and oxygen will only help if there is no uteroplacental cause. If the cause is uteroplacental, we are just wasting time giving her oxygen and maybe harming by releasing free radicals. And another thing, when in doubt, if it's a borderline CTG, like you said, suspicious or non-reassuring, but not pathological, what we can do is that we can use the contraction stress test or we can use the scalp stimulation test. So these two help us.
Dr. Tamkin, on reviewing the literature, the intrauterine the resuscitation are basically turning left lateral IV fluids and oxygen. I would like Dr. Manju to please give her inputs that when we have to resuscitate.
Can I come in here?
Can I come in here? Guideline I was talking about.
Can I come in here? Yes, Dr. Tamkin is absolutely right. Giving oxygen to a mother who is not asthmatic and who doesn't have any bronchospasm does not actually improve the fetal hypoxia, because she's, as it is, taking an adequate oxygen, and in the atmospheric oxygen she's taking it, and it increases free radicals actually, which may cause further acidosis. So what is absolutely required is a left lateral position. That is really very beneficial.
I also agree with Dr. Tamkin that oxygen
discontinue these oxytocin in case too many.
Yeah,
There is no
discontinue.
any aggravating. So, Dr. Tamkin, thank you very much for bringing this point, because oxygen is not going to help and it is not at all recommended. And once upon a time, for the audience, once upon a time, the fructodex and dextron, which actually created a good number of acidosis to the fetus. For all the audience, that even sometimes the pharma people come and they say that it is for fetal distress, please don't use it. And oxygen in many ways cause a many neonatal damage like retinopathy or prematurity and so many things after the baby.
Direct to the
So
fetus.
we have to be very careful. So very much we are too much. This is also one complaint from the people, that now it is CTG, and we are focusing drop tone of fetal heart and nobody is looking at mother. So mother is also there. She is not, everybody is concerned about the baby. So to Dr. Munjupuri, Nivedita, I am taking 4 questions for the 4 people. It is sort of ready, rapid fire. That how do you instruct? Do you use enema? Do you allow her to do food? About the posture? So a quick review. It is not something very life threatening, but for Nivedita, that you are doing, you are still advocating or using enema and still not. It is there, enema and perineal shaving in labor. Nivedita,
No. Routinely, we are not using giving enema, or we are not using perineal shaving as such. But yes, if we do when we have episiotomy and premi, we do trimming of the perineal pubic hair.
Or if the part is very bad. So
Yeah.
enema is not there, because once upon a time admission means one castor oil enema and that enema, soap water enema. So it should not be the practice. But still, I will like to say that enema does not increase contraction. But there are few papers that in no enema group, there is a little lower infection rate and neonatal respiratory tract infection. And that might relate to sometimes soiling and the baby aspiring. So enema should not be given, but I am also pointing out 1 or 2 studies which shows it. Dr. Vijaya, perineal shaving, I think she has done answered. What's your takeaway for the perineal shaving? Still, it is a routine, or it is what do you do? Vijaya is there?
Yeah. Dr. Vijaya.
Vijaya, something wrong with her internet? So I think we can
Yeah,
go
now only it has got.
Yes.
Yeah.
Vijaya.
It was unstable, I think. Perineal shaving, yes. Again, just like enema, nowadays they say don't do perineal shaving, and it's more for a comfort level from the patient side or the person who is doing, but otherwise it's not advocated. And because the pores open up, and they say that infection rates go up. So if you are do it a little earlier, meaning towards close to term labor, but otherwise in the labor room it is not advocated nowadays. And they say sometimes while doing, we have often found some scratches, some cuts, incision, something and all can happen. The only thing is sometimes while we are suturing, sometimes especially on the episiotomy line, it gives a little bit of relief if there are not many hairs there to take the sutures. But otherwise, nowadays the guidelines are not to do the routine perineal shaving.
So we are doing less and less intervention to the mother.
Yes.
Dr. Sukumar, for food and fluid in labor, what is your takeaway to all audience? Allow how much to eat, what to eat, and a little instruction. Do we really give them instruction or not? कि ये खा लो, you खाओ या नहीं खाओ?
और ये तो इंडिया में तो यही बात है, क्या खाएंगे और क्या नहीं खाएंगे. तो ये तो सारे all the day people are asking क्या खाएंगे और क्या नहीं खाएंगे. The guidelines.
क्या ठंडा है?
For laboring, what's your takeaway, Dr. Sukumar?
I think if it is a low risk pregnancy and she is in spontaneous labor, then light food, particularly any light food can be allowed. I mean, light solid food can be allowed. But if there is a slight higher chance of converting to GA or converting to cesarean section later on, there may be a good idea to allow clear fluids. So there are 2 groups. One group, we just allow clear fluids, and second group where there is not much problem is there, we can go for the light thing, heavier food, थोड़ा सा बिरयानी खा लो ये नहीं करते हैं. We are not doing it. A little bit of sandwiches is allowed, but most of the time, if you are thinking about it low risk, she is in a little bit advanced labor. Suppose she is in 4 centimeter, 5 centimeter. We do encourage to take some clear fluids.
So thank you very much, because it is important that patient must have, the woman must have the energy to go through the labor, but she should not vomit during the time of delivery. And sometimes, as you say, that if there is any issue, though with the regional anesthesia, the aspiration issue has been solved and a good airway protection, but still we have to be with the very, very simple food. So this is another thing. One thing is again confusing, that the NGOs are also pushing the clinician too much. So one way, as an obstetrician, we want to have the at least IV line accessible, if not IV fluid. And one way they say that don't intervene too much and let the process happen on its own. So one thing is that IV access line is a must for all women. And if you are using fluid, then what is your choice of fluid? Because again, there is a issue, because we are still seeing 5% being used, and no IV access at all. So what is your takeaway? I can say we can take from the Dr. Achla Batra. She has been quiet since a long.
Yeah, I think we should have an IV access, because labor is very unpredictable. Something can happen at any time. So we should have an access. And if she is taking fluids or food, then we need not put IV fluids. But if she's not able to take because she doesn't want or she's vomiting, then we should give her IV fluids. And the best fluid would be DNS, because she needs some energy also. So just 5% is not enough, but that will not, maintain her circulation. So DNS is a good option if she has to take, and you have to give, at least 250 ml per hour gives good results.
So thank
if
you.
she has no condition, she is a low risk.
Yes. IV accessibility is a desirable for all situations, anything happens. So this is one message, and like Madam says that we need energy, and the crystalloid DNS is
Sadhna, just one thing, because if you are going to ambulate the patient, keep her walking, let us not get her pinged with the IV fluid. Sometimes it happens that just because she's having IV fluids, she's not able to move. So
Dr. Surekha wants to
I
add.
agree with
I want to add
the question is there. What you have
Can I add one thing here, ma'am? Yes,
yes,
we are talking about alternate birthing positions. When we are talking like human care, and we need to have the patient ambulatory for that. So depending on that, yes, IV access for all is important, but let us not, start giving IV fluids to all patients. We do not require. Secondly, once you start, the protocol of giving IV fluids to all patients, that becomes very difficult in situations where the patient is quite anemic. In institutions, we are still getting patients who are having, a severe anemia, and we need to individualize according, again, what we have said, 250 ml per hour. So that also depend on the weather conditions also. I think that when you have a dehydrated patient, when we have summers like in Wardha district, too high temperatures, their need may arise of giving that 250 ml per hour of hydration. But I don't agree that they have to have the IV line all the time. Just the line running, I don't agree to that.
No, it was not line, it is IV excess. Excess doesn't
IV
mean
access
IV
is
fluids.
okay.
Yes,
IV access is okay. May I complete, and then maybe you people can add?
And
I
also,
do agree
Sadhna,
that
sometimes if she gets too much of IV fluids, I mean, if once
There
you
is
start
also-
and leave it, I understand it's mostly an IV access that we are worried about, not the line. But IV fluid, sometimes the bladder fills up so fast, they don't even get up and go to the bathroom. And then that is going to also do some dystocia or PPH and all those things.
Good point.
There is no recommendation also, ma'am. The NICE guidelines also do not recommend any IV fluid.
Correct.
IV access is okay, but the NICE guidelines are not recommending a routine IV hydration for women unless there is a need.
That is the point. That
Dr.
is the
Manju,
point.
you wanted to say something, Dr.
About
Manju.
birthing position, actually. Now we are already from that.
Can I just
Dr.
make a
Manju
point,
wants
Dr.
to-
Sadhna, with your
Yes,
permission?
yes, sure.
For low risk patients, I would not even go for IV access. Where is the need to say, let's leave everything to the nature and natural? Whenever indicated, we can always start an IV. I mean, how many patients do you think would that IV access be required? So that's one thing. And the second,
No, I don't agree.
I don't agree also.
No,
I
ma'am,
don't
we
agree.
also give IV access to all patients, but no fluids.
Because
We encourage our patients to walk.
Let Dr. Manju please
patient-
complete. Let Manju
No, I've heard all of you, so I'm just giving my opinion on that.
Yeah,
yes,
please.
yes.
Need to leave the patients to themselves.
I agree with Manju Puri ma'am here. In the
Yeah.
EMOG guidelines, also Lakshya guidelines,
No, we are
guidelines
not supposed to unnecessarily do that. So that
we
is
are not unnecessary. We are not supposed to put, that
Utilization.
IV
Yeah,
big access.
Yeah,
Not
so that is one thing. Yeah. Secondly, I will not do anything which will restrict the patient to the bed. So that comes in your delivery position and labor position. So no continuous CTG, no continuous IV line. So nothing. For me, a patient who is low risk should be coming to the labor room, and we should just supervise her. We should look at her hydration part. In case we feel she's dehydrated, she cannot take orally. That's all. Then we can give, but not otherwise.
Actually, Dr. Manju, you are saying whatever, it is very, very correct. But actually, with what is the obstetrician pressure? Let's be like, we very, very, what situation we are facing. One time the all court decision board says that every patient should have some blood cross match and group ready, every laboring woman.
That is justified, Dr. Sadhna.
Yes.
That is justified in case you want to, but otherwise, I'm telling you that, even when we talk about admission CTG, for medical legal point of view, for a practitioner, it may be okay, because you know that the baby is okay. That is all what you're going to get from it. If you are able to listen to the fetal heart sound, which is okay, CTG is not going to give you any more information as far as your admission CTG is
Only
concerned.
your own.
That is the only advantage. Because we said we do not treat CTG. We do not take. So if you assess the patient.
And when we are talking of guidelines, ma'am,
Dr.
we have to
Manju,
take
I
care
would
of
say
all
that
the health facilities. Right? When we say a generalized guideline, a uniform guidelines, we are not talking of a particular, we are talking of a uniformity. We are talking of institutions, large volume institutions. We are talking of peripheral conditions. We are talking of CHCs. We are talking of PHCs. We are talking of, midwifery-led care. So let us not give the idea that each and every patient has to be put in an IV cannula. It is not feasible. And that and there may not be training also in that regard. So if it is needed, yes, but for those patients who are low risk, who are coming in your labor, who nothing is wrong with them, just putting the IV access is not needed, not recommended. No guidelines say.
Dr. Sureka. And last rapid fire, that is about birthing position. All obstetricians are like comfortable with delivering in supine position with the patient. So with all birthing chair, water birth, and all the thing on the net, and we don't know. So your experience. Anybody has the experience for resident are accustomed to get delivery, second stage delivery in the alternative position. So
yeah, we
are having, ma'am.
We are having
already.
chair.
See, I have worked in MJMS Sevagram for 20 years. Now, since 1 year, I have shifted to Jawaharlal Medical College, and I can tell you about the alternative birthing position in a rural care. See, we are a rural institute, and in the rural care, we have been able to run this whole program of alternative birthing position by training. First of all, you have to train your staff, you have to train your resident, you have to train yourself to accept this change, to a positive change, to a more humanized, more natural birthing. So you have to first train yourself and accept it, and then provide the infrastructure. In MGIMS, we are having the birthing tub, we are having the birthing ball, we are having birthing chair, and yes, each and every resident actually is trained how to go through these alternative birthing positions. So there is a positive trend. Of course, it is not going to come into practice so fast. It needs a change, a time period, a duration has to be given, but it is possible. And once we start accepting this change, then and there only these unnecessary interventions we are going to avoid, and we are going to change towards a positive, where, you know, unnecessary intervention, unnecessary cesarean section, unnecessary episiotomies, these all will come when we accept that natural birthing is going to come into being, and that is through our own positive and through our efforts. You know, the most important effort is training and availability of infrastructure.
Thank you very much. Because in house of residency, we see the patient when they were not being able to deliver, they put on the squatting position, and we say, oh, what they are doing, what they are doing. But what you say, science have proved that right, and because supine is not good for the fetus and not good for anybody, gravity and the course of labor. So thank you very much, Dr. Surekha, because you are doing it. So that instills the confidence in the obstetrician all over the country who are with us, that it is doable and it is good for mother and the baby. And the people science actually shows us the way to actual science. So Mitra, to you with for antibiotic prophylaxis.
So let's now start the next round of controversies.
It's getting really hot.
Are we walking the talk? I mean, are we walking the talk? That is the basic premise for this question. That in our patients and in your setups, Dr. Achla, Dr. Tamkin, and Dr. Vijaya, we know all three are representing different sets of patients. So what is your take on antibiotic prophylaxis in labor, vaginal delivery? Do you use
we are not giving antibiotic prophylaxis in normal delivery.
Okay, never mind.
Giving,
Let me just say the questions. Please go back, Dr. Sadhana. I just want your answers. Yes, no. And if it is yes, then what? If no, then why not? Your choice of antibiotic timing and your choice of antibiotics. So, Dr. Achala, we go with you.
In vaginal delivery, without any episiotomy, without any instrumentation, we are not giving prophylactic antibiotics at all.
That's good. Then if you are giving episiotomy, Dr. Sadhana, let's just complete the whole question. With episiotomy, are you giving antibiotics?
We are only giving it till the patient is in labor room, but after she goes to ward, we stop antibiotics. We don't give.
What antibiotic? What is the choice of your antibiotic?
We get this amoxiclav, so we give that, and then when she goes to ward, we give nothing.
Okay, Dr. Tamkin, what is your take on this question?
For us, whenever she's in preterm labor, we have to give the GBS.
No, ma'am, it's not preterm. Don't change the question.
So when it is
in labor, vaginal delivery.
If she's in labor and she's normal vaginal delivery, we do not give unless the membranes are ruptured for more than 18 hours or she's running temperature. And then we add gentamicin as well. So we are not giving any routine antibiotics to our patients.
To all your normal.
Or maybe when there is sepsis.
What is the socioeconomic status of your patients? Are they all well nourished? Are they all healthy, not anemic? Do you have any?
I don't think so. I don't think so. The socioeconomic status of the woman is going to make any difference to whether I give or not.
Anemia?
Anemia would definitely, yes. Severe anemia, we would like to give prophylactic antibiotics, but again, only for those who have membranes ruptured, who are running temperature, or who have past history of some culture is available, or they have past history of sepsis in the neonate.
And if your patients are receiving episiotomy,
we are not.
Do you add antibiotics?
No.
Okay, Dr.
We are giving prophylactic, that is all.
Yeah, Dr. Manju, I'll take the last, your response last.
Yeah,
Dr.
for me.
Please, what do you do in your setup? You have got worked up patients, I believe. They're coming from a very good educated background. What protocols do you follow for antibiotics? Dr. Vijaya?
Yeah. Can you please repeat? Yeah. No, for me, for us, the normal deliveries, normal delivery, no antibiotic. And of course, cesarean, we give just one dose after the clamping the cord at cesarean. And routine use of antibiotic is not there. And if at all we give only when the ruptured membranes is there. It's not a pre-labor, but a mature rupture of membranes, and only we give, or we give when a diabetic we give. And the usual choice of drug is only ampicillin or sometimes we do give cefuroxime or the cephalosporins. And so we do have also amoxiclav. So in case we suspect a little pyrexial condition or chorioamnionitis in cases of premature rupture of membranes, then even if it is not preterm, we do give amoxiclav.
Ma'am, can I ask a question here?
Yeah.
Is clav safe in pregnancy and lactation? Because it is contraindicated.
No, we give only one dose, and it is only if preterm labor or this, then only they say it can cause necrotizing enterocolitis. Otherwise, one dose only we give. So that's all, and that is only when there is suspicion of pyrexia or this. Otherwise, our usual choice of antibiotics is only ampicillin or cephalosporins.
So Dr. Manju, please round
And
it
we
up.
don't repeat the dose.
So basically, we have very robust antimicrobial surveillance in place. No antibiotics for normal delivery, whether anemic or anything. Normal delivery, no antibiotics. For episiotomy, if we are able to give one shot of prophylaxis within 1 hour of stitching the episiotomy, then it is fine. Otherwise, normally the patients go on amoxicillin 8-hourly for 48 hours, and that is it. And even if we give prophylactic, it is only ampicillin 1 gram stat dose, and that is it. Because the wound is clean contaminated. So if any organism has gained entry, that would be killed by ampicillin, and you don't need to give anything else. So that is the point.
Good asepsis and antisepsis protocol
That of course,
has to be followed in the labor room. You
Yes,
have to enter the labor room following all the protocols, keeping your, whatever footwear should be outside, wearing the cap, the mask, washing your hand washing technique prior to any intervention, reducing your cord vaginal examinations to a minimum where it is required, and then again hand washing for every vaginal any procedure. These are the things which really are the standard, and these are the guidelines. So thus, for any vaginal deliveries, normal deliveries, you don't require any antibiotic. Only one shot of cefazolin in the cesarean section, and no antibiotic, unless there are indications, like you said, the diabetic patient is there, or a patient who is having some susceptibility, then you can. But there is in our setup also, there is a good the committee is there which will monitor and supervise this your antibiotics.
So the good clear take home message that from a high volume practice, if these things can be maintained, then smaller units, definitely it's easier to translate. So the take home message is that follow the infection protocol.
Madam, I would like to add that I have seen even operation theaters where the street clothes are not changed, and obstetricians are entering the operation theater without changing the clothes,
With all apologies, I would say
we follow the guidelines, we follow the protocols for antisepsis and sepsis and OT protocols. If all that is followed very well, and your OT safety measures are followed, very cleaning, using carbolic acid before taking the patient on the clean sheets, all that is followed, I don't think that antibiotic is a need. All that we need to train ourselves, our juniors, our staff, is to follow all these protocols, and that is going to keep the surgical site infections to a minimal, and you can contribute towards this antibiotic stewardship.
Okay, can I just, Dr. Mitra, can I just ask others about whether the high vaginal swab or anything you do in PROMs or whatever, the opinion?
Yes, we do. For PROM, we will send a high vaginal swab, and also if needed, the cervical swab also are sent in patients of PROM. All patients, before doing a vaginal examination, also before doing any intervention, first thing to do is do a speculum examination and send the HVS.
That's
So one thing Vijay said that you give antibiotic after cord clamping. Your takeaway?
No,
it should be just around 30 minutes before.
If she is already on antibiotics, shifted from the labor room, but in elective cesareans, the anesthetist usually give it after we cut the cord. So but in labor, if she's been in labor, we give it earlier. Before
can I
even
just add something? So now the protocol is shifted to giving it within 1 hour of the incision. The body should be flooded with the antibiotic at the time. At peak should be there at the time of the incision.
Yes.
So we need to change this practice.
We need to change
Give it
it.
up.
That's why I
Yes.
took up this should be.
I think that's why,
Actually,
you highlighted it. Yeah.
so the message to the audience very, very clearly from head of the departments or extremely busy units is that from the time when we learned that the patients would be discharged with an antibiotic coverage for 5 or 7 days. So let us be more economical with respect to use of broad spectrum antibiotics by maintaining very good surgical aseptic techniques, and OT and the labor room culture should be developed. And as Dr. Surekha and Dr. Mathan, many in private sector, even if the obstetrician is following the rules, but the others are not. Our anesthetists just walk in. So you keep offering
I've
them.
seen that, ma'am.
It's very sad. Yeah. Thank you so much. That was an excellent interaction.
Message.
Yeah, with our labor rooms in summer having 100 deliveries in a day, I don't know how much we can do. That is the reason we give in labor room, because we have 100 deliveries in July, August, September in one day, in 24 hours.
Dr. Achla, antibiotics as a replacement of sepsis is just not agreeable.
Yes.
So,
I know it is not agreeable, but tell me, we have 8 tables. How much can we do? So, like Dr. Thamkin said, just at the time of episode
We have 20 tables, ma'am. We have 20 tables.
It will not make a difference to the infection rate.
In
Or
any
rather, it will result in more resistant type of infection.
Absolutely. It is more harmful than any good.
Actually,
For episotomy, one shot should be okay. One shot.
Yeah, that's what I'm saying.
That's exactly what
When
Dr.
she's
Achla
in labor room, not afterwards, because there has been a study in Lancet also in which they have found that giving one shot after episiotomy or instrumental delivery
is good.
Is
good.
So,
Dr. Achla,
good.
I am
still controversial.
I fully agree to that. I am not saying no antibiotics for episiotomy. I have not said that. I said that for antibiotics, one shot because it is a clean contaminated wound.
For normal labor, no. For normal delivery, no. I agree.
That's exactly.
We are not giving, even with 100 deliveries, we are not giving.
But no 7
for
days
normal
antibiotics for episiotomy also.
So I
Thank
think
you very much. I think we have covered and a very, very clear message. First of all, prevention, good aseptic precaution. First of all, secondly, no antibiotic for the routine vaginal delivery, that is unassisted, and with episiotomy or with assisted vaginal delivery or cesarean section, single shot of antibiotic. Because this is the clear message, and all panelists agree to it.
Absolutely.
So now coming to
Unnecessary interventions in labor rooms like catheterizing a patient, unnecessary, we have seen that patient is not able to pass urine, or patient, you don't want to send the patient to pass urine, just put the catheter. All those interventions are leading to infections. So good aseptic precautions and good antiseptic, keeping the labor room area clean, all that, you footwear, first of all, footwear has to be outside. So all that if you follow, no need of antibiotic. Please don't put,
unclean hands,
unclean hands, unclean surface.
Actually, that is the thing which that people are not willing to come to institution because of unclean toilet and unclean labor room. So this is the problem.
That is changing totally, madam. If you go to the public hospitals now, you can see many facilities where the infrastructure has changed so much, you feel like you are in a corporate hospital. So now the public hospitals are changing, and Government of India has taken the Lakshya program, wherein the public hospitals are if you come to Wardha and you go to the district hospital here, the whole infrastructure has changed so much that you will be, surprised that this is a public hospital, district hospital, the civil hospital, what they used to call earlier. Now it looks like a corporate. So
all southern hospitals have been turned into corporate hospitals. Actually, the infrastructure.
The infrastructure of district hospitals has risen with the NRHM contributing so much amount of funds, and the national mentors going and hand holding these areas to bring quality. Small projects are being done there to train to use partograph, to train for.
That reminds us, Dr. Surekha. Let's just stop this and Dr. Partograph.
And now it is yes, we are coming already. The panel is set the that it is the something we have no IV line, or yes, only IV access, no antibiotic, no anemia, no shaving, 1 CTG, and everything is fine. Patient is mobile, taking clear food. So now she is in active phase of labor and having moderate severity contraction. So our takeaways in recent time, first of all, partogram, how much is used? If it is not used, what are the issue? And secondly, the change definition, what the average globally, that majority of cesarean section for dysfunctional labor happen around 4 week, 4 centimeter dilatation, that is around latent phase. And they have shifting the definition of active phase from the 4 centimeter to 6 centimeter. So what are your concern? Are you happy about it, or you are not happy about it? 6 centimeter is too late, many consultants say. So how frequent internal examination, that adds to sepsis, privacy, and so many things. And how to monitor, it is a local, verbal, or partograph, or written findings. What is your takeaway? I will say Surekha, Nivedita, and Dr. Manjupuri for this.
So, ma'am, in our setup,
you are doing and what you add.
Madam, in our setup, we are having the e-partograph, which was taken up as a very novel sort of intervention 5 years back. And in that, the inputs were taken from one international organization called as Jeevdaya Foundation. And in fact, MGIMS Sevagram is the pioneer for e-partograph. And there the e-partograph started, because we know that the paper partograph was, all of us, we know that it was being filled retrospectively. So the ideal for monitoring the first stage of labor is the partograph, but in all setups we saw that the resident used to do a retrospective sort of filling. So this was started as a pioneer pilot project by Jeevdaya Foundation. This was developed, the software was developed, the inputs were taken from the faculty, and this started, and we had trained ANMs. So because there was a shortage of staff, we trained ANMs to 8 hours duty, and we trained the ANMs to chart on the electronic photograph, and that has given a very good.
I think Janitri people must be very, very happy about it, because they are actually doing this thing, e-partogram and e-monitoring of labor, and they also say that the ANMs and the resident doctor can do it. So I think Arun must be very happy about it. Nivedita has done, she is in Bokaro, a little low resource setting state, we can say, and she has worked a lot in Manyata and many Manyata training. So Nivedita, how you cross the barrier? Do you have used e-partogram? And if you are not, then how you train your staff in Manyata training and at your, that how to fill the partogram? But
so far as Manyata is concerned, we are still training with that paper partograph. We're still teaching them how to plot on the paper partograph. But I think the major problem we are finding with the partograph is a lot of doctors, a lot of obstetricians themselves are not using partographs, or probably are not very comfortable using partographs. So hence, because they are not comfortable, so their staffs are not using it. My staff initially, my staff, we were using the paper partograph because that's what we learned from the Manyata. But now they've got so habituated. Now we are using the paperless partograph. Now we are like, they know that, okay, she's 6 centimeters. That means she should be fully dilated after 4 hours. So she should be 10 centimeters.
Mental partograph.
So they're doing the mental paperless partograph. So now we're doing the, I mean, we do both. We record it on paper because, as Dr. Surekha said, it is basically on the after, it is a retrospective paperwork. Most of the times it is after the delivery that they plot it on paper, because when I go, I see the partograph done and in the same handwriting. But I think they just calculate and they say like, okay, 6 centimeters, so 4 hours she should deliver. That's it.
Dr. Manju.
I would like to share one experience from Osmania Hospital, Hyderabad. It's a large volume load hospital in Telangana, and there the partograph, actually they were not filling the partograph at all. Why? Because it was not available. First of all, it was not available. So availability of partograph in the public hospitals is a problem. So sometimes we have to agree that resource constraints are there, some administrative problems are there, and non-availability is one of the thing, and lack of training is another thing. And then of course some of the consultants feel that it is not, may not be of use too. So all these barriers we have to break. And of course as I have said, if one the mentorship is there, then probably this would change, and then we could go towards the good use. Of course, along with that, some apps also have come up now, wherein you can do the partograph, the electronic partograph on your Android phone also. So now it's becoming easier, for the healthcare professionals to use this one very important tool in the first stage of labor.
No, I
Of
think
course,
lack
for
of
second stage,
willingness
no
is the
such-
maximum thing. Availability and all is there.
Tamkeen and Dr. Manju Puri.
Dr. Manju,
Dr.
you're
Tamkeen, what's
Basically, Dr. Sadhna, we have crossed all these barriers. We've done it as a QI project. In my labor room, partogram is used and a prospective partogram is used. Everyone is supposed to put the notes in the partogram. So if a consultant takes the round, the senior resident takes the round. So everyone puts the notes there. So that is why now everyone is using a partogram. So we've looked up at all the points which Dr. Surekha had made. कि वो partogram मिलता नहीं है, training नहीं है. So we have an induction training of the first years when they come for 15, and then we have a labor room induction training every month. So उसमें कोई question ही नहीं है कि किसी को partogram नहीं आता है, और सारे लोग on board हैं, और सारे लोग एक ही कागज में सारी एंट्री करते हैं. So बस सारा काम खत्म हो गया. But we are doing it from
Dr. Manju Puri, for the convenience of the audience, please tell us the partogram that you all are following. Dr. Sadhna, please show the approved one.
So no,
new one, na?
Which one are you taking?
No, Mitra,
4 or 6 years.
No, we are still following the modified WHO.
Please, Dr. Sadhna, please project that one.
Previous slide. Yeah. So
Modified this one.
This is this one. No, not this.
The next one.
Yeah.
Where you are starting the thing from 4
centimeters. Yes. We are following this one. We are following this one.
We are following this one, but
So,
abhi we are wanting to graduate to 6 centimeters. Abhi hum wo nahi kiye hain.
Okay, Dr. Manju, for the convenience of the audience, please tell how you instruct your juniors to plot the partogram. I know it's a very basic question, but now that this beautiful graph is there, so please go step by step.
Yeah. So basically, you look at all these components here. You have the, babies, mother's information here, baby's information here. You have the labor progress here, the third, column, and then you have medications jotted here and the maternal well-being here, right? So here, basically when the patient comes, they would put it and they will remember that they are going to start it only if the patient is 4 centimeters dilated. So they do not start it, if the patient is less than 4 centimeters, the partogram does not start. So that is what is important. And the first reading has to come here. The patient is 4 centimeters here, right? So when they do a PV, the patient may be 4, she may be 5 or whatever. So wherever the point is, you can put the point, on this line, where whatever centimeters dilated she is. And then you follow it, every 4 hours, you're going to do a PV. So basically, if you look here, I don't have a cursor on me, but if you look at the progress chart, so on the progress chart, you have these small boxes and then you have big boxes. So every big box would be 1 hour.
Yes.
Right? Big box would be 1 hour. So they would plot the next reading after 4 hours. So that is it. And here they would plot the fetal heart sound. Here they would, they will, put the fetal heart sound. Then they would put the color of the liquor and molding. I don't know whether everyone can see. So basically there are some parameters which have to be done 4 hourly. That would mean the, PV findings, and then the BP record, and the temperature is 4 hourly. Rest all is half hourly. So rest all is half hourly, and they start once the.
One question about this thing, 6 centimeter, because many obstetricians say that it is too late actually to start. It is 6 centimeter because we have to cover episiotomy, second stage and third stage. So we will be a little fast. Yeah. We are already around 7.
Dr. Sadhna, WHO says 5 centimeters. So anything between 4 and 6 should be okay. But I think we should go and give more time to the patient. So if we are not, be 6 centimeters, it's a good idea. The primary cesarean section rate will go down. That's what is my feeling.
So it is because the duration of labor has
to 6 centimeter. From
Sorry?
4 to 6 centimeter, it takes more time than 1
Yes.
centimeter per hour. That's why
Absolutely.
we need to give a patient more time from 4 to 6 centimeters. So it is logical that we do not rush and do some intervention if the patient is taking more time. So that is the logic behind shifting it to 6 centimeter. In large volume hospitals, I think it is good idea to shift to 6 centimeter. Of course, then there are some arguments against it also. So those who are continuing with the 4 centimeter don't agree actually. But you need to give that time, that for the dilatation to occur from 4 to 6. It takes more time than 1 centimeter per hour.
Yeah, sometimes 4 centimeters continues for a long time.
Yes, even it may take 4 or 5 hours.
Yeah.
So right from 55 to 2014, it is all about relaxation in second stage time, in arrest of labor definition and start of active phase. And we have to think it and experiment in our labor room practice that what works best, and does it the prolongation of time result in a good outcome, or it is resulting in optimized outcome. And actually we make the evidence, and we make our experience make the evidence. So this is the slide which we want the audience to really have a look, that how from 55 to 2014, in between there was no change in definition, and suddenly in 4 to 5 years we are having more understanding of labor, especially for high rise of cesarean section. So this is very, very important. And what we say, it is challenges, and already Nivedita has said about the paperless partogram and the e-partogram. So we are going straight away from Mitra. Now she is going to deliver, and you take episiotomy. And we have already crossed the time, so I think within by 7:30 we will sum up to the newborn care. So Mitra, you take.
So like fashion is a habit of going around in circles, from tight pants to loose ones to tight pants. So from no episiotomy to no episiotomy again. So I will ask Dr. Achla, Dr. Sukumar and Dr. Surekha to give their inputs on the timing and the benefits, the disadvantages of episiotomy. That which is the commonest of operation, which is given the least of izzat. And what is your take on it, Dr. Achla?
We are not giving routine episiotomy for a long time now. We are only giving it.
In primary also?
In primaries also, we are not, because we had done few studies in which we found that even primaries, they only get first degree tears most of the time. Some get second degree, but episiotomy is also a second degree tear. So we are not routinely giving episiotomies even to primaries, and multis definitely not. And selected patients who require very big baby or very tight perineum, or we need to do instrumentation, then only we are giving episiotomies in our institution.
Okay, Dr. Surekha, your take on this?
I agree. So it is now since 2007. These guidelines have come, and since then we have been trying. See, again, I have to say that it takes time, it takes training, it takes acceptance, and we need to keep on monitoring, all the time, because residents behind our back may do something else. So you need to train, and over the period of time. So now it is since 2017, now we're into 2020. So over the period of time, the change has occurred, and yes, no episiotomy for routinely for primaries. There are certainly indications in which we will follow that, and of course you are going to the right mediolateral episiotomy with a good angle, and you need to be very careful that at the time of crowning, if you are giving, then it happens that if you need a episiotomy, then it has to be a good episiotomy. You cannot give just a small cut and just finish it off. So if the indication is there, then it has to be an adequate episiotomy at the appropriate time, and mediolateral, no medial episiotomies at all. So at the right time. So all these guidelines are being followed, and we are monitoring also. So that is again area where we monitor very strictly, because there is a presentation of the departmental, all the procedures at the end of the month, and it has to be documented how many episiotomies have been done, and within the acceptable 30% episiotomies, that we maintain.
So Dr. Sukumar, what is your take on the routine or indicated use of episiotomy? And in your own department, how is it managed?
I
All
think
private.
I will answer this thing in two phases.
Yes.
One phase is, fortunately or unfortunately, I was trained where the recommendation was made. In UK from 89 to 99, the selective thing came in. So there was no routine episiotomy. It is only the selective episiotomy, and I was trained in that way.
Okay.
Now, coming back to India, I also follow the same thing and advise the juniors. But nowadays, hardly I get the chance to do a normal delivery nowadays. So only thing I can advise, teach, and tell and do the protocol. Even if I enter the labor room also, I think they say, आप निकल जाइए, आप थोड़ा सा करने दीजिए तो हम मुझे करना है. So for all practical purposes, coming back to India, I just follow the protocol, what has been, or the guideline, which has been suggested by the RCOG, and I've been trained there and practiced there for 10 years. So selective episiotomy, what Madam Bhatra was telling, exactly the same thing, that no routine episiotomy, only in case of rigid perineum or there is a big baby or instrumental delivery, we go for the episiotomy. And yes, rightfully that it is right material episiotomy and not a just a small one. थोड़ा सा दे दे, ऐसे नहीं है. देना है तो देना, नहीं है तो नहीं देना. It's not थोड़ा सा दे दे का कोई मतलब नहीं है, because all episiotomies are secondary triads. So basically,
agree.
Yes, so selective episiotomy.
I know this is not in the purview of my domain, but just for the audience, from the esteemed panelists, I would say that in primaries, we often find that the perineum is tough and it takes longer time for the head to descend. So what will be the safe time with guidelines and your practical experience, that when will you, for how long would you ask your resident or the doctor to wait? In second stage, active bearing. And do you recommend that when there is delay in second stage, would you give an episiotomy? Dr. Manjupuri, Dr. Achita, Dr. Sureka, Dr. Sukumar, Dr. Tanke, one of you.
Actually, Mitra, to label a delayed second stage, the problem arises when you shift the patient onto the table earlier. So it is the impatience of the obstetrician rather than anything with the patient.
Very good message. Please define that.
Correct.
I would like to give it at the time of crowning, if at all I have to give. And I would give it at a 60-degree angle from the midline. And that is how I would go about. And I would go in for restrictive episiotomy. Yeah.
Yeah,
And when you
I also think it is invariably the restlessness or obstetrician's distress.
The staff.
Yeah, and I suppose now we have the second stage of labor again divided into two stages.
Very good. I wanted that.
It is previously we used to say full dilatation and 2 hours from then or 3 hours from the full dilatation we have to deliver. But now we have again in that we have a little latent phase and an active phase. So I think we have to give due respect to that. And as they all said, don't shift into
allow
the labor room
alternative birthing positions. Dr. Mitra, as you have said, that certain patients take longer period of time, that is because you are asking them to lie the supine.
Yeah.
So if you ask them, you try the alternative
squat. Yeah. In fact, we make them squat over the bed also, and that progress, because we know the obstetric curve is different. So when you are lying down, obviously the pushing does not happen in that obstetric curve. So that is what it is. And I don't know, just wanted to add whether perineal massage helps, whether that resist maneuver helps. It has been mentioned, but I think all that need more evidence to say, because they say you can make the perineum a little bit. I mean, all these are mentioned.
The perineal massage, I don't know, but when you do that hot water, you soak a cloth in hot water and keep it at the perineum. It definitely helps in making the perineum softer, and episiotomies are not required. I don't know,
And
I
also
fully
some
agree.
would say
So,
the Ritzen's
Mitra, I will say you conclude the message to audience about it, because
Start.
I'm very happy to see all the
No, but
experience.
I think actually why I'm not speaking is because Dr. Manju in 3 lines has actually summed up the whole thing. That please do not start counting the second stage before the patient does active bearing down. Give adequate time, no impatience. And if you give, you make sure that the angle is such that after the episiotomy is given at crowning, it will naturally decrease, come toward the midline. So it should be more lateral, as has already been said. I think you can go to the next round.
So now we are coming to, we will go a little fast, active management of third stage of labor. Now the things, when we did Helping Mother Survive program in 2013, and it was alarming. We did a lot of program in Delhi hospital, from Lucknow to the small cities, and every unit, what the initially the panelist was saying, that every unit was having their own way of AMTSL. So we really want to advise Dr. Manjupuri, Dr. Tamkeen, and Dr. Vijaya to give a clear message that what are the now currently arms of active management of third stage of labor, why it is very, very important, and how we can like assure uniformity in this practice, because it is the most dangerous stage.
I think active management is very important. Third stage gives rise to a lot of incidences of PPH, because if we don't rather mismanage or don't manage it well, and it's very important. And of course, there is we have a set protocol for management after the delivery of the baby. We give one is of course the cord clamping, which we do after 2 minutes, but at 1 minute after delivery itself we give oxytocin intramuscular. We give 5 units, although some advocate even 10 units, but we give 5 units intramuscular and into the intravenous, because always we have intravenous line for all the patients, so we do give IV in drip as well. And then we wait for say about a minute or so after the baby is taken out from there. Then we allow the placenta to separate, but at the same time control contraction. If you find all those signs of placental separation, the apparent lengthening and the fresh gush of bleeding and all, that is how we also tell our this thing. Now in case we don't do a controlled contraction, then obviously there is, they say some blood oozing happens in the retroperitoneal compartment, and you don't have an evidence for hemorrhage as well. So better to do and separate. And if you don't see the placenta coming there in 20 seconds, then we will again wait, because it's very important to do that at the contraction. We should not do, and of course in that we have that posture of keeping the uterus up towards the fundus, and this we don't advocate fundal pressures during even delivery of the baby. As much as possible we don't do that. We don't allow the nurses to do that. So baby delivers by itself, and then we wait and then do a controlled contraction and deliver the baby. And of course oxytocin has to be given. And once the
Dr. Vijaya
separation
says 5 units. 5 unit intramuscular, 5 unit IV, and then the delayed cord clamping and the control contraction in all the patient. Any panelist will like to differ from this practice?
10 units intramuscular.
Can I just, we are following the
Yes,
WHO protocol.
WHO protocol.
MI immediately after the delivery of the baby, and this is the most important component of AMTSL. Uterine massage we are not doing, we are following controlled contraction, and uniformly for all term and preterm we are following delayed cord clamping.
Yes,
Right.
I
Absolutely. Absolutely.
So this is the thing. It is not with the delivery of anterior shoulder, and 10 unit oxytocin for all. There is no absolute no contraindication in which we cannot use oxytocin. We cannot use prostaglandin in many things. We cannot use symptometrin in many situations, but oxytocin is the thing. And Dr. Tamkeen has already said that uterine massage is not recommended. A word about control contraction, because like when we are doing panels or the discussion on maternal collapse, still people are like having this uterine inversion as a cause of maternal collapse. So what's your takeaway about the control contraction?
push the hand over the fundus upwards, and then hold it
No,
firm and
matlab
then
it's used
have to-
like new resident, new nurse. So what's
It
your
has to be
take
done
away?
by a person who has been trained in it.
Skilled.
Otherwise,
Yes.
Even if the
it's better not
person
to
is
do
new.
it.
Madam, I want to make a point. The new
Yes, yes.
resident will always work under supervision initially under a trained person. Similarly, a nurse will also be trained under a trained person, and thus no labor room woman will be attended by untrained people. So the guideline, the protocol will be handed over from the one new to the other trained to the new, and the guideline whatever WHO is saying, we are totally following that. 10 units intramuscular within 1 minute, control contraction, no massage, and the for the CCT you have to train well, and we are even using the virtual mannequins to train. So we are having the mannequins on which we train, and very nicely we can train how the inversion can should be avoided. And so proper training is the key to all these protocols being followed.
Why I'm keeping this question, because WHO says all over
Yes.
that you use it, you can omit this arm. You can omit this arm if you don't have the confidence in it, and the most priority.
The
the
WHO is
most
saying that
important is, yes,
So
most
may I give my input for the last 1 year? What I have been doing is in all my vaginal deliveries, of course, because ours is a private setup, so usually all the babies are fine. So I put the baby on the mother's abdomen, let the
Same
mother
here.
hold
for
the
all.
baby, and I wait for the cord pulsations to stop. Having given already the syntocinon 10 units intramuscular, we actually don't even need to do controlled contraction because the uterus contracts so beautifully. Two inputs: one is the intrauterine intramuscular syntocinon, and the other is contact of the baby and the mother. And then you take out the placenta when the cord pulsation is over. And so almost, the PPH has really come down in my own particular practice. So I think AMTSL is the cornerstone is IM syntocinon within a minute. That is the most important thing. And
anything about use of misoprostol? Like many people say that there is no need of this thing. No?
I have stopped misoprostol totally for last 4 or 5 years
AMTSL.
in normal delivery and cesarean sections. And my PPH
Any panelist for a broad, not for your institution, like people are having delivery in many settings. What is the status of misoprostol in AMTSL only as a substitute for the injectable oxytocin? Any takeaway?
So it can be used according to WHO, it can be used instead of syntocinon because there's no problem of storing. Storage at the right temperature for oxytocin is very important at 2 to 8 degrees centigrade, so which we are not doing most of the time.
So thank you very much, because about our path project oxytocin, actually that was the eye opener in 2012, that in any chemist shop oxytocin was keeping like any injection, and that's why oxytocin is not effective when we need it most. So we really worked a lot of program, and now I think many people according in all societies, people are aware that oxytocin should be kept in refrigerator, and misoprostol actually comes in this way because it does not need that refrigeration facility. So this is very important. You are all from the peak institution.
So
but
Sadhna,
actually
you said
So for PHC deliveries, and for even for if there are any home deliveries taking place or something, I think misoprostol is a fantastic drug for AMTSL.
So Sadhna, is it misoprostol you give per rectal or oral?
It is should not
sublingual.
it should not be given. It should be orally. Parectally is not the active management of third stage of labor because it acts after 60 minutes actually. So it is for prophylaxis. It's okay. Otherwise, no professional body recommends actually parectal. It is orally or
Madam,
it is
one input I would like to give with your permission regarding misoprostol. It was being used few years back. But now, with the abuse of misoprostol for certain other things.
Yes. That
now
is
the
another
question
issue.
is coming on misoprostol also because in our EMOC project we used to recommend 600 microgram of misoprostol because of the problem of storage of oxytocin. That was coming as a recommendation, and WHO has given that. But in our country, certain things which are easily available, which were cheap,
for induction and so many rupture uterus we are.
So these are coming.
Do you give something to, I mean, sometimes it works as a laxative, no? Sometimes you do have a side effect.
Yeah,
Madam, my
causes a lot of diarrhea and vomiting.
Yeah. So preventively, do you give antiemetic and this and then give misoprostol?
Make my point, please, here. In Maharashtra, what has happened because of this, the Prevention of the Prenatal Testing Act, the BCPNDT Act. Now, what has happened that misoprostol has come into the under supervision, and every one single tablet of misoprostol has to be accounted for. So that has come as a deterrent actually. For PPH also we have to keep that misoprostol ready, and so it is becoming a problem. Though WHO is recommending as a second line drug for prophylaxis of PPH, still in our state we are not very easily available. Misoprostol is not there.
I confess that my reason of deleting misoprostol for PPH as a second line management drug is simply because of what point Dr. Surekha has rightly mentioned, that, and this is for the audience, very clear message, that every single misoprostol tablet, it is in your pharmacy or under your supervision, has to be accounted for, because that will be very carefully inspected by the drug inspector. So that is why I stopped doing it. Surekha, I'm glad that you pointed out this.
So one thing, it is a good drug, but it is an abuse of drug actually. But it is still a second line domiciliary setting. It is recommended.
In domiciliary settings, you have to have misoprostol because you can't have oxytocin.
Yeah. Provided they have the history of asthma and respiratory disorders is excluded.
No. Misoprostol is not asthma, not a contraindication.
Not in misoprostol. It is for the prostaglandin F2 alpha. That is prostaglandin.
It's only liver disorders that misoprostol, you have to be careful.
So we look forward to heat stable oxytocin that will really help in the tropical country and unijet preparation. So this is the thing that is still all over the world. There has been wide variation in AMTSL, and many people like nurses and many settings, they are not using it. So we have to be very, very clear about it. And this is like a Copenhagen conference, and what we take the picture when we Nivedita was with us for the Manyata project. And this is the thing that I will come to a little bit later on, that the drug should be available, because we cannot do anything if the drug is not available and refrigerated. So please keep a fridge close to labor room for all audience. These are the small things, and made the good number of oxytocin, because we don't know which is going to have the PPH and something, and store drug properly and check it whether they have been used in night and they are available or not. So this is very, very important practical thing. Cord clamping, I think we have taken
covered already.
Delayed cord clamping.
Delayed because it is for anemia free India. Actually, this will go a long way for the anemia free India. So we are going
skin contact.
Even for cesarean section, delayed cord clamping should be recommended.
And actually, it causes circulation.
Yes, of course.
And decreases the chances of necrotizing enterocolitis and intraventricular hemorrhage. So there is all the recommendations in favor of delayed cord clamping.
And public health is, we are having so much of anemia, like 50% of our population is anemic. And the pre-toddler stage is very, very important thing for population for anemia. So our obstetrician contribution to make India anemic free. Dr. Tamkin was saying that she is not doing uterine massage in the postnatal, like after delivery. So I think that message is okay. Every panelist agree to it, that we don't do the uterine. So we are going to it, that we must have the drug about it. Now coming to a golden hour, we will go very, very fast now in 5 or 10 minutes, that what we are supposed to do in golden hour or in the 4th stage of labor. So good message, because we
Dr.
have
Achula.
most of complication in around 3rd stage and the 4th stage. So Dr. Achula and Dr. Sukumar, what the golden hour, what we should do?
Actually, the golden hour is the time when we can, sail through the after delivery part, or we can have, problems. So at that time, monitoring of the patient is very important. We have to monitor this patient for 1 hour for her having bleeding or sudden obstetric collapse, which can happen. So every 15 minutes, patient has to be seen, her vitals have to be seen, her uterus has to be palpated, and bleeding has to be seen in that hour to avoid all these things.
Dr.
I think that's it. And little bit about shock index, if Dr. Sukumar want to add, because this message we want to give to audience. Very, very simple thing for shock
I think this 4th stage is very clear that the most of the complications after the delivery, what happens is mostly within the first 1 hour to 2 hours. And that is the reason the concept of taking care, I entirely agree that we should not just delivery happen and you leave the patient. It should not happen. And we should be very careful at least 1 hour after the delivery, whether it is a vaginal delivery or it is cesarean section, and noting the vitals, and particularly recommending the juniors and the nursing staff the importance of it. And if it happens, we can act early and we can prevent early. So that is the importance to be done.
So thank you very much. We have to be.
Dr. Sadhna,
Yes.
I know that the golden hour comprises of the vital signs, and especially to the early detection of PPH and any reason for seriousness. But in my private practice, because I'm single-handed, what I have added in that golden 1 hour is at the end of 1 hour, when the patient is in the room, the nurse gives the first wash and does a gentle PR in all the cases who have a big episiotomy. That I have included in my first 1 hour assessment, because I've seen that few times people have had a hematoma, and in private we cannot afford that. But then it can happen to anybody. That is my personal suggestion.
And breastfeeding.
Yeah, breastfeeding.
Breastfeeding
That
is started on delivery table in every delivery.
Yes.
And one thing about, again, it is heartening that everybody is saying that now our public health as well as the private health facilities are like coming, and we have a fully equipped labor room, and we must know what is like we should have all cardiac monitors and resuscitative system as in OT. So Mitra, you take with the, I think we have covered essential newborn care. And you
we
have
should
taken
also
all
talk about Muse score, ma'am. The early warning system.
yes, short, yes.
Dr. Sureka, please summarize it.
Question यही था कि Mayo, shock index and rule of 30. There are 3 things.
Muse score we should train. See, these
which-
things come with training only. So we need to be well aware of Muse scoring, which is an early warning system, including all the vital parameters. And you should download that score, and have a training, proper training for your staff, how to recognize and now what is the early warning system. And then we can, stratify our patients of whether they need immediate care, what kind of attention is needed. So green, yellow, red, all that, a Muse scoring system is a very good scoring system. And of course, shock index, the shock index is your heart rate upon your blood pressure. So that can give you a very good idea about what the condition of your patient is, and very nicely you can.
And we can put the chart of Muse as well as an.
Yes, you need to
have all the vital signs.
And
I think very important is assessment of the hemorrhage in the 3rd stage.
Yeah,
I mean,
Dr.
that has to come as a routine.
I would just like to add
blood
something.
loss.
I would like to add that when you are working in a facility, there is something like a rapid response team. So basically the idea is that whenever somebody thinks that something is wrong, they will come and assess the patient and escalate or de-escalate the care. So if somebody is giving you an unnecessary call, never try to put down that person कि देखो तुमने कहा था कि patient ठीक नहीं हो, patient तो ठीक है. So that is if the pulse, blood pressure, everything is okay, but the sister feels that something is wrong, you have to believe her and come and assess the patient. Then you may escalate or de-escalate after 1 hour.
Great, Tamsin. That was something very wonderful. That अगर हमको किसी दिन नहीं लगा तो don't like discourage them so that next time then really we have the problem and they will be hesitant to call or not to call.
I tell my patients also that if there is any problem, come to the hospital. Even if it's a false alarm, does not matter. Nobody is going to rebuke you for that because really don't want to miss.
So it is very good that and the rapid response team that if something
very good,
we have to be very, very clear. And all eclampsia tray and PPH tray, which as a Foxian we are promoting, it should be ready with already if their PPH tray should be there, which we have all uterine tympanoid, all drugs, gloves, catheter, so that we don't lose time in collecting the thing. And every nurse know, every person know that it is PPH tray, it is eclampsia tray for the ready resuscitation, because even if we identify, we have to manage then and there. So this is the thing. Mitra, for essential newborn care, I think you will like to add, or we have already covered skin.
I think we have covered, but
I think I want to add is that we should not be doing suction now. Like we used to do vigorous suction, that should not be done if the baby is crying. No need for any suction.
Even in meconium, no suction. Unless the baby needs it.
A clear-cut message that every delivery should preferably be attended by a neonatologist or a person trained in resuscitation. That should be the clear message, so that we don't do any shortcuts or cutting corners. Because in today's day, the prized possession comes and is not attended by a trained person, that will cause problem for us. And I just really want my panelists, all of you all are in bigger institutions, but like Dr. Nivedita, Dr. Vijay, Lakshmi, and myself who are in private, I think the need for documentation should be really stressed.
Very important. Very important.
I think counseling.
Dr. Vijay, how do you manage your records?
No, ours is a computerized system, even in the antenatal records. So whenever, even in OPDs, we have completely computerized histories, and everything is all computerized. And anything we counsel regarding anomaly, regarding whatever the irregularities, we document. So no question of a patient saying anything. And suppose there is a need for amnio, patient refuses, that also we record, we take a signature, and everything is documented. And as far as labor is concerned, again, there is no regular birth attendant issue in our labor room as such, but in Tamil Nadu, all over the government hospitals, it's compulsory to have a birth companion. So that anyway, at least he is watching the person who is there as a birth companion. But besides that, the counseling, the documentation and everything is very, very important, and let them know whatever we are doing at every stage, because we know the complications which can happen. I mean, everything is not as smooth as we want it to be. So we do keep informing and we document. So
Dr. Nivedita, your take on this about documentation?
Documentation is of paramount importance. I mean, that's the only thing I think which can save your skin. And our documentation is on written on pen and paper, because even for the communication and documentation, we tell them to write that they have been informed about the complications. I have a birth companion. I always insist on a birth companion in the labor room, because I feel it's a part of, it saves my skin. A birth companion knows what is happening in the labor room. She knows that the labor is getting prolonged. She hears the fetal heart sound being heard. So she knows what is taking place. And she's the one who actually goes out and tells the other attendants that the doctor is trying their best and the patient is not cooperating or whatever it is. And then there is no problem about paying up also. They pay up for the instrumental deliveries also, because the birth companion gives every information.
That is, I think, a very, very good and a clear message for the private sector people, that if we have not been practicing with a birth companion, it's high time, because especially in primaries, when they want us to do normal delivery,
yes,
we are struggling. So it is really, I also get the husband or the mother-in-law to stand there to see for themselves the effort of the patient and the effort of the doctors. And
Dr. Mitra, in other hospitals outside the main institution where I practice, the husband is a part of the labor room. Let him realize how difficult it is for wives to do the birthing. Let him become a little more
ma'am, when I get husbands, the problem is when I get husbands into the labor room, the wife creates even more nakras. And I find the mother-in-law is the best birth companion or the sister-in-law.
And,
They're very strict.
and one thing I think we have to keep in mind that all the CTGs, if we are taking and this, it is important to do the Xerox or whatever printing, because in a few days the wax paper is going to go off, and any evidence is not going to be there to save your skin, especially if you are deciding on fetal distress or whatever. I think it is very important to have the this thing Xerox done. Otherwise, it will not stay on the wax paper.
Dr. Surekha, your input.
I just wanted to say regarding the birth companion, my inputs are that we have to start counseling for the birth companion in the antenatal period itself. You know, you cannot just think about deciding on the birth companion at the time of delivery. We have to start sensitizing them beforehand. You know, when they are doing their antenatal, we are having yoga classes and all for these women, these rural women also. We are having yoga classes, antenatal classes. So at that time, we should start counseling for the birth companion and let them have a choice, you know.
So, hello.
Can I just add regarding birth companion? We introduced birth companions in our setup. All 36 weekers in the antenatal period, when they are counseled for birth.
In-law, and she's not.
Hello.
Yes, Dr. Tamkin.
Yeah.
Very comfortable with it, then again she'll not cooperate. So I think the choice of birth is women.
So all 36 weekers, they are counseled regarding and they register their birth companion. And yes, surprisingly, each of them choose their mother-in-law. This is what we found.
Good.
Good.
Yeah.
This is, I'm sharing this prerequisite for birth companion. Actually, not anybody can be. She should be with experience of childbirth, because again, say somebody faints and somebody shrieks, not having any communicable disease. Be careful about and all enthusiasts having clean clothes, willing to stay throughout process of labor. ये नहीं कि मेरा BP बढ़ गया, अब मैं जाके सो रही हूँ. Should not interfere with work of hospital and treatment procedure, and should not attend to other women in labor.
That's very important. That's what they'll do. They'll leave their patient and look after somebody else.
So I think this is very important, and there has been diverse experience, and we have already very good experience of panelists and all audience, and we can change our mindset that it can be helpful. It may not be intrusive or intervening or crossing the boundaries. It is help. And we can create like Asha a cadre of birth companion ki pehle se dekh lo ki kisko karna hai, so that they can help. So thank you very much for wonderful discussion. Every panelist, great session, great inputs, and finally we end with this: simple things matters for many, and high tech is needed only for few select situation. Whole panel was for the same view. Make your labor room equipped, train your obstetrical staff, make a good team, make good protocols, and follow the protocols which are evidence-based.
So can I request the panelists to give one message each, one liner from all of you? Dr. Achala.
Yeah, I think training your staff is very important. Training for the labor room and having protocols in place, printed protocols in place in labor rooms. That is very important.
I think what will be your message to all the practicing obstetricians of the country? Dr. Tamkin.
Okay, evidence-based medicine can be practiced everywhere. We just have to make some effort. And I would like to add great moderation, Dr. Mitra, Dr. Sadhna, great summing up. हम कहीं भी भाग जाएं, आप वापस हमें take home message पे ले आते.
Thank you. Dr. Sukumar, sir, Dr. Barak, please.
I think it's labor is a teamwork. I think you should emphasize the importance of teamwork, because that is the important thing, and train and retrain and retrain, because there will be times new people will be coming. So it should be an ongoing training of the base process, whether it is episiotomy, whether it is CTG, whether it is partogram. That is very important, and you should emphasize and respect the whole contribution of the team. Madam told that usko डांट नहीं डांटना, वो बुला लिया so नहीं डांटना. So that is a very important thing, and that is the key message.
I think all of us.
I think the woman should also be. Yeah, ma'am, please, ma'am.
She's
please.
part of the team.
Please,
She's
ma'am.
part of the team. She's part
Please,
of the
ma'am.
team.
Yes, please consider the woman as the most important stakeholder who is part of the team, and consider her needs as the priority. Whatever she is consenting for, please do that. Even episiotomies, don't take it that she's giving the consent for it blindly. You need to counsel the patient about what you're doing, and you need to communicate. And of course, standard of care is evidence based. Do follow the protocol, believe, and yes, respect the woman.
Okay, Dr. Vijay Lakshmi.
I think that the respectable maternity care is all around, and we need to really focus on that. And also it's a teamwork, but at the same time, let us be guarded, watching, but at the same time, don't hesitate calling for help. It's very important in the labor room that we identify the problems early and call for help and ask for help. If you are juniors, seniors means juniors, or even the peer groups, wherever it is available in whatever way. I think it is very important.
Dr. Nivedita.
I think labor is a laborious process, both for the woman who's undergoing it, her relatives, as well as for the providers, the doctors and the paramedics. So each person should come together, as I said, a teamwork in a proper fashion, and it should be done for every patient, everywhere and every time, so that there is a standard quality everywhere.
Thank you, Nivedita.
That's very good. I think that is very important, because the power passenger and the pelvis, they are unpredictable.
The passage.
Patient, her relatives and the doctors are all predictable. We all can actually work in a team.
And I think drills must go on.
Game of
So,
patience.
I think we will sum up the session.
Thank you.
No, don't say goodbye. There may be few questions. Rita, Dr. Rita, please, if there are any question you like put up for the answers.
There are a few
Rita,
questions. Well, the key
yes.
messages were very clear, but still we have some questions. There is a question, ma'am, should there be partograph for breech, delivery and IUD?
Intelligent question. Who would like to take the answer?
Yes. If you're allowing a woman to go into labor, she needs a partograph, because even if an IUD, you cannot allow a woman to go into obstructed labor with an IUD. So what are her contractions like? Whether she's progressing, that is equally important. The mother also matters. So it's not just a baby who's died.
Can
Yes,
I just add to that?
that's it.
For breech, the recommendation is that you follow the same limits
Exactly.
of the partogram that you use for a vertex. And of course, you have to have a partogram for, though recently the evidence is that the usefulness of partogram is questionable.
Yes.
Yes.
Partogram is very useful in
very
peripheral areas.
Three important
The usefulness of
landmark papers.
partogram is in peripheral areas is there.
Three important landmark practice-changing papers. They were republished in the Lancet as well, and they have started questioning, even the Cochrane Review 2013, they have questioned the use of partogram, but I won't agree to them. For us, and in my 25, 30 years, whatever practice I've been doing, how do you know she's in obstructed labor? How do you know she's crossed the limits? You say that what is stage 1 arrest? 6 hours of syntocinon with no progress. If you don't have a partogram, how will you define that? So there are two things which are just, contrary to each other. But yes, the meta-analysis and the evidence is that it is of doubtful, but definitely not for us.
Personally, I practice ETD, the paperless partogram.
That doesn't take care of fetal heart and fluid. So many things are missing.
No, it doesn't take care of many things.
It is mental.
I'll take up next question.
Yes,
ma'am. Yes, ma'am. Ma'am, what delivering position?
People in the house are getting, angry.
They're waiting for dinner.
Yes, Rita, quickly, be quick.
Yes. What delivering position will cause minimum or no compression of fetal umbilical cord?
Sorry.
What question?
Which delivering position? Delivering position will cause minimum or no fetal cord compression.
There isn't any relation of the fetal position.
No, I think
No relation. So
Yeah.
go ahead, there is no relation. And next question. So clear
Just
message.
avoid supine position, that's all. Avoid supine position.
So when it is supine position, why the baby is being affected is because of the pressure over the inferior vena
Inferior
cava.
vena cava.
No, no.
The
I
venous
was just saying for
Yes.
general,
Yeah,
avoid
Yes.
supine
And
position.
uterine artery.
it is not direct here.
Yes, ma'am. Should we do admission CTG irrespective of early or active labor?
Admission तो ये है ना कि when
Admission
patient is
CTG,
come
if patient is active or early labor, latent phase of labor.
Low risk as per guidelines, no, but your practice translation as per your own,
Setup.
Actually, we have answered that.
Always no admission CTG in low risk, and that is the recommendation. And admission CTG is when the patient is coming to you in the labor room, whether in labor or not labor. When you say admission, that means when the patient is coming to you, with the history that she is in labor, she may not be in labor, she may be latent phase. You want to send back home, that's your decision.
And my question is that if she is not in active labor and you want to have the observation and patient want to go home, then we have given clear message that it is better to confirm that the patient has come and she must be having some problem, and it is a document as well as reassuring to doctor as well as the patient. So Rita, next.
Yes, ma'am. That's all. That's all, ma'am.
So we can conclude, and we will invite Mr. Arun for final thing. And again, I owe a heartfelt thank who accepted the invitation at a one call, and we have a real wonderful panel and wonderful discussion. And I always like fighting, and I put deliberately few questions with that the panelists start fighting. So that was great and hard. Dr.
No, we agree to disagree, ma'am. We do not fight. Agree.
But yes, that was so. Mr. Arun, you want to
I have a power off my hand.
So I think like the discussion was too deep that it's almost an hour extension.
Really, yeah.
And I really enjoyed. I'm not from the doctor background, I'm an engineer, but I can understand all these terms working in this field since last 5 years. And I was completely able to correlate the kind of a challenges, the kind of a thinking process, and somehow we incorporated all that into the product which we have actually developed, innovating products. For example, the fetal monitoring, continuous or intermittent based on the risk of the patient. And we found a lot of challenges around the CTG machine in terms of the belt, the positioning of those sensor, and mobility is also now becoming one of the important factor during the labor. And we also saw that challenge. The thermal paper printing, which fades away over the period of time. On the another side, there was a lot of discussion on the partograph, where the protocol for a lot of parameter is every half an hour, few parameter is 4 hour, few parameter is 2 hour, and filling that partograph after delivery or with the delivery. So I actually spent my lot of time into the labor ward, I think more than 100 hospitals, and each and every kind of a setting, which was also a PHC, which was also a medical college, which was also a kind of a corporate hospital. So so all these things, how we are solving this. So we made a wearable patch which just stick on the abdomen, and which is monitoring fetal heart rate, contraction, and maternal heart rate continuously. And it is wireless. The pregnant woman can move and walk around in the labor, and it is just a patch without belt. Number two is it wirelessly transmits the data to a mobile application, so which automatically generates partograph for you. So now if you look at the challenges with e-partograph only, still you have to manually enter the data into the app. But here, the fetal heart rate, contraction, and maternal heart rate can automatically come from the device into the app, and you can fill each other data, which is manual observation. Number three is the documentation, where all these focus has come. So we have included each and every parameter starting from she get admitted till she get discharged. We have included each and every parameter into our mobile application, and you can actually take printout of that case sheet at the end of the day for your own medical record purpose. Number four is you are always not available in labor ward, so you can actually access the data on your phone at any time, wherever you're traveling or sitting in OPD or wherever you are. So I think we have considered all these challenges, considering the challenges of each and every kind of a setting into our solution, and which is coming out very beautifully. And I would be happy to work with each and every one of you in terms of pilot, study, or any research for betterment of to saving the life of mother and baby, and to ease the life of doctors, staff nurses, healthcare worker. So I would love.
You follow everybody, because everybody is leader and everybody is innovative.
Yes,
So
yes, yes.
you have the perfect audience, and please follow it. So Arun, can we sum up the session? I think we
Yes,
can.
yes. I think and personally, I would love to thank you each and everyone for taking out this time. And I handed over to Dr. Sadhna for and summing.
So we sum up the session, and I thank Rita also for giving her time, and she is always first to call what to do, because it is first time that she is comparing the session. And Rita, you did it very well, very pretty well, and she is from my own team. So thank you once again, every panelist. Dr. Leela Vyas is not here, I think, but we owe a thank for being a chief guest and a very good wisdom pulse from out of experience. And as a from Janitri, I thank Mr. Arun, because it is only your persuasion that made it possible, because at this time I was so busy that I was not thinking that I will be able to do it, but we could do it, and it was wonderful, thought-provoking, brainstorming and learning experience. Thank you everybody. Dr. Tamkeen Khan, because she was also occupied and she came in time. Thank you very much, Tamkeen. We know that all things require extra effort and your commitment also. So Rita, final thanks from you, and then we sum up. Dr. Rita.
You are on mute.
Unmute, Dr. Rita. Unmute.
Before we
sorry, yes. First of all, ma'am, I thanks Dr. Sadhna, ma'am, for making me the part of your this academic session. And I thanks all the other renowned teachers of our country. And it's great for me also. It was great to the whom I was I took help in the whole event. Thanks to all, and good night to all of you. Thank you.
Thank you. Bye. Bye.
Bye.
Bye.